Okay, I'll start sharing my screen. I'm
You're all
sorry,
good.
guys. What a
Yeah, so we're
crazy morning.
we're gonna make some lemonade this morning. How about that?
Yeah, what that was a very timely
Not intentional, but
quote, Jake.
I've heard Anso make some great lemonade, so let's go for that.
uh here, let me share the slides. And that should be good. Okay. Can we see okay, Jake?
I can see. Yeah.
Okay, wait, I'm just stuck with, okay, here. Okay, should we get started? Are people back? I'll take that as a yes.
Yeah, I'd say let's do it.
Yeah, okay. So, as you know, this is a very last minute presentation. That being said, Josh Wang actually gave us the really good idea to have some backup presentation as chief, and it turned out to be very useful. So thanks, Josh. Let me just move that away. I don't want to see my face when I'm presenting to you guys. Okay, so we'll talk about the consent rules in Quebec and basically when it matters and the key things you have to keep in mind, okay? That is my usual disclaimer when I do a presentation on a legal topic. Basically, I've been in the emergency room more than in a courtroom. So if you guys have any question, I'll be happy to take them. That being said, I might not have the most up-to-date information, but I have no issue going and getting it for you. So don't hesitate to ask questions, okay? So we're gonna look at very few things. I want this to be a simple presentation. First thing, what's a valid consent? What are the rules that apply to a consent in an emergency situation? And what are the rules that apply when the situation is not urgent? We're going to look at these two situations for 4 categories of people, okay? The adult who has no other issue, the adult who's not able to consent, the adolescent who's between 14 and 17, and the child who's 14, who's less than 14 actually, okay? As I said, the idea of the presentation is really to provide a simple frame of mind to know what rule apply to your situation and to just make things hopefully easier in your head if they're not already. As you might already know, law is the business of exception. I don't think there's a use here to know all the nitty-gritty ones here, but I think it's really important clinically to know the major one. So it'll guide you practice and it'll make you more comfortable in the decision you make. The main focus in the presentation here is basically when the patient refuses care, because this is where we have most of the issue and not when they agree. Having an issue with, okay, I'm sorry. Okay, so a few general principles. People have the right to accept or refuse healthcare. Obvious. Healthcare cannot be forced on anyone. So all of that is easy enough. And of course, there are exceptions to that. If not, the presentation would not exist. 3 elements to a valid consent. It's voluntary, it's capable, and it's informed. Okay, 3 things. We'll look over these things quickly to make sure all of it is understood. So let's say that, so voluntary refers to free will. So let's say that a police officer brings in during a ED shift a man from the airport because they want you to proceed to a full medical examination because they think the guy is trafficking cocaine. They've got a high suspicion that he swallowed a condom full of cocaine and they want you to take it out. So without much surprise, your patient does not consent to the exam. So what's the legal issue here and what is your next step? I'd like to hear maybe from some residents or staff, how would you approach that situation? And what's your main legal concern?
I'd be struggling just as when police want you to tell them the history and the build up to, like, basically in essence whatever you talk to the patient about, and the patient that it does not need to let the police know of any of that information. I feel like this runs along the same lines where it'd be difficult to follow an order from the police for evidence that they want that is literally in that person.
So you bring up the one of the key points, saying that we don't have a mandate. There's no paper saying you have to proceed to that examination. And you have a patient who's an adult who's saying no. But what about if the police is at bedside and he ends up saying, okay, sure, I'll do it, whatever. What's your main worry here?
And Sophie, if I may, would in this case you be acting in the patient's best interest? So for example, what if the condom burst and then he has, for example, like a acute intoxication? So if you say no, based on the patient's, for example, let's say not consenting, and then something happens, then wouldn't you be responsible for that?
Well, that's a very good point. So how would you approach that situation? What would you go and say and do? You're there, you go in the room, the guy is there, he's got a condom full of cocaine in his body. You haven't seen it, but it sure looks like it. And police is at bedside. You go in the room, what do you do?
But my question is, answer, how would you know? So the police are basically, they have high suspicion, but based on what? So for example, let's say you go in and then you examine him against his, for example, against his consent, and then you find out that there's no condom, or so there's no basically drugs there. Then you would be liable for a suit, no?
So let's go. So you bring up good points. So let's go back, okay? So basically the main issue I wanted to bring up is that even if the patient ends up saying, yes, sure, go ahead and do the exam, okay, in the absence of a mandate and no judge is forcing him to do so, okay? Just the police is just bringing the guy to the emergency room. Well, in that context, you should really have a high degree of suspicion that his consent, if given, is not voluntary. So what I want you to take from that example is that, let me just admit that person, is that you should do two things. First, you have to talk to your patient when the police is not at bedside. They're going to be pissed about that. You can just ask them to stay out of the room and be close, but you need to speak to your patient when the police is not there. You brought up a really good point. You need to explain the serious risk to the patient of having this condom full of cocaine like explode. So he needs to be aware of that. And that in that specific case, if he doesn't say yes, you'll have to have a mandate to pursue, okay? So we're not gonna open the whole box of mandate, like court mandated exam, because that's a whole other box. But that's what I wanted to bring you on. Given that for some reason, okay, that you need to make sure it's voluntary. And there's other situation where you'd have that apply, and you'd have to be careful with the unique son. Does he want the inheritance, or is he actually acting in the best interest of the mom? Okay, so you have to be careful about, is this voluntary? Going back to what's a valid consent, it's voluntary and it's capable. How do you assess for capacity of a patient? You need to ensure that he understands the nature of the illness and the diagnosis. The patient has to understand the nature and the purpose of the treatment. What are the advantages and the risk of the treatment? And what are the risks of not having the treatment? Okay, so all of that makes sense, but that's also what you have to document when a patient is refusing something. Your documentation needs to be around what I just said, okay? Third thing, your consent has to be informed. So most obviously, if you've been through the above step, your consent at that point will be informed. You also have to think though to give the other treatment alternatives, okay? So me as a doctor, I'm suggesting that. That being said, we can do X and Y, okay? The common issue with this is that we tend to give better explanation when the patient consents versus when he refuses a treatment. We'll go in length when he refuses a treatment, and we won't do as much when he consents. I want you to remember that people are allowed to be stupid. We have daily examples of that. So remember that a stupid decision does not mean that they're not capable in law. Oops. Okay. So we'll look at urgent and life-threatening. not urgent, in the same category of 4 people, okay? Situation 1, urgent and life-threatening. That's the main exception we deal with almost daily in the emergency room. So you know that one. You have to make sure that the patient's life and physical integrity is really at risk, and that it's not possible to get permission from the patient in time or from someone else who could consent for the patient in time. That if that's not the case, then go ahead and save that life, however that might be. In that specific situation, what are you allowed to do? You're allowed to give the only necessary treatment to stabilize their life until you can get a proper consent, okay? So, serious and life-threatening, patient is an adult. If you cannot get a consult, once again, we deal with that quite often. So go ahead and give the care. Make sure that you check if there's any advanced medical directive in the chart, or if there's anything cluing you in that the patient might not want that. That being said, in a situation like this, if I didn't have any specific documentation, like you go ahead and you give the treatment and you'll deal with it later, okay? I'm sorry, I'm really having, for some reason, I'm seeing half of my screen. Okay, Jake, are you seeing my whole screen?
Yeah, I'm seeing your whole slide.
Okay, sorry. So what about the adult who's not able to make a decision on their own? It's a similar process. So you'll check for any anticipated medical decision. Was there a previously well-documented level of care? And if you can't find, you don't have the daughter at bedside, you don't have family, you don't have anybody, you go ahead and you treat. So these are rather simple case. Whoops. What if you cannot find the level of intervention or any legal document, and you end up intubating a patient, and then you notice right after that there's a no intubation directive? How would you guys deal with that? You just passed the 2 patients intubated, and the clerk comes in and saying, he's a no intubation.
What I've seen done at that point is either you try and get like family involved and stuff and see like if there's any extra information you can get. If it's like very, very clearly written in the chart, does not want to live on ventilator, then a one-way extubation plan would be done. So essentially you extubate the patient, you kind of optimize the best you can, and then extubate. And if they end up going to respiratory failure at that point, then there's no plan to re-intubate that person.
Would you make sure you speak to the family before, or would you extubate the patient on the spot? Because there's a clear, let's say that medical directive or level of care was signed a month ago and it seems valid.
I mean, that piece of paper is the directive that you need to follow, but it's a bit of a sensitive situation, and so you have to be kind of careful how you go about doing it, because if you end up with family who says you intubated and now you extubated, and it's a very sensitive kind of moment. So
it is a sensitive moment.
I mean,
that's why I'm bringing it up.
Yeah, you follow the paper, but usually before extubating, I would have a quick discussion just to sort of inform the people who are around or the people who are important to this person what the plan would be.
So in that situation, my point on this is, sure, you have a direction saying don't intubate. Given the situation, you had to, because you didn't have that paper and he was dying in front of you, okay? So there's 2 things. First, you have to document that well, the timing of things. So here I give an example saying, given severe altered mental status, the decision was made to intubate stat, as no one was with the patient to guide the decision. The instruction not to intubate were discovered upon review of the chart after the patient was in fact intubated, and the situation was explained to the family. Once the harm is done and you have not respected the patient's will, I wouldn't bulge that tube before I talk to the family. Would that make sense? Like you wouldn't take the tube out just by yourself without talking to the family. Once the harm is done, it has to be explained to the family how things happen. I would document that, but I would wait before I take any tube out. Jake, let me know if there's anything in the chat that pops up, okay?
And Sophie, good question. What if you don't find the family? And would you call, what do you call it, the legal representative? I forget what it's called. Do you have to, or no need to do that?
Well, at some point you'll have, like, I find it hard that situation where you wouldn't find anybody. Okay, so that's always that's when you go into the nitty-gritty of things. If you have to, my advice would to get the medical lawyer of the hospital involved, just to have somebody backing you up or another physician backing you up. But I find it hard to believe that you wouldn't find one person who's in charge of taking these decisions, or one close relative, you know.
Sometimes you have psych patients, stuff like this, and you always get the consent from this legal institute, which I forget its name. But okay, I got the answer. Thank you.
No problem.
And there is.
I'd be careful. Yep.
Sorry, yeah, it's a similar question from the crowd, just about, is the onus on you to find that person, or is there, if you foresee this being a difficult situation, are you the one that's responsible for finding someone to determine their goals of care?
In an urgent situation?
Sorry, actually, I'll just read the, so it's this quick question about the duty to obtain collateral information. When you have a patient who is clearly not capable of baseline, and the question of whether to treat arises, what degree of onus is on you as the ER physician to try and speak with the next of kin to determine their goals of care?
Well, as for any physician, it's just that you have the extra burden to do it in often an emergency setting. So if it's urgent, then you'll act regardless. If you have to act now, do it. And if you can't find anything, just document you can't. That being said, as for any doctor, you have, before you do a procedure, before you do something, the onus is on you to see if what you're doing is in accordance with what the person would want. I don't think that's specific to an emergency physician. I think it's specific to any doctor. Would that make sense to who asked a question?
Hey, Anthony, this is Gemma. Yeah, maybe I'll just clarify. Hi. So I great talk, by the way. I think the question I had is, let's say you have an elderly patient who comes in with like an acute delirium, but they also, have many comorbidities and probable cognitive impairment at baseline. And let's say they're coming from a long-term care home or something. When it comes to pursuing active management, so not just in a crashing situation, but just pursuing active management, what level of onus is on us to speak with their family and be like, hey, what are the actual goals? Because I find what happens often is that just doesn't happen. And so I'm just wondering, legally, are we expected as the ER physician to make sure that we do obtain some form of collateral information, or at least try? Is that something that we should be documenting in the chart? I understand, yes, in general, doctors should be doing this, but I'm just saying, pragmatically, I haven't seen it done much often.
The answer is that yes, we should. That being said, I'd have to review the jurisprudence in saying what's the exact onus on us. That being said, it makes sense that it does. Before you do something, if we'll go through how you deal with the absence of consent when it's not urgent. We'll go through it in the presentation.
Okay.
So maybe if that doesn't answer your question, we can go back to that. That being said, a lot of things that should be done by the book aren't always done. And partly I want to leave you with the message that it's okay most of the time, given you do have the constraint of time. But you should at least either involve social worker or somebody to help you get collateral information.
And Sophie, it's Monica. 2 quick points. One with regards to what Gemma was asking. To a certain extent, I believe the idea of the fact that they transfer patients to the hospital to a certain extent is an implied consent for treatment, right? If they do not want treatment, then the idea is that they're not supposed to transfer them. So if they're at end of life and they're a level of care D, often there is a no transfer sort of rule in their chart, and they don't transfer these patients. Often when they've been transferred, a lot of these facilities will have already spoken to a family member to ask whether or not they want the patient transferred. But I do believe to a certain extent we're protected in that the presence in hospital does equate to a certain extent to an implied consent to care. Am I correct in that, Anne-Sophie?
Well, yeah, definitely. If there's no paper and there's not much, yes. And you'll do what you have to do in the meantime, and you document that there's no, that the patient cannot consent at this point, and that you cannot find anybody. And then in that context given to you, you will treat in the meantime.
Yeah. And my other question,
I wouldn't, my threshold, just to make that clear, my threshold to treat would be much lower than the threshold to not treat, you know? It's more difficult to make the decision not to treat, and that's the one you have to be very careful with.
Yeah.
Nobody's going to fault you to try to help people.
But if I may, and I think I agree with the Christine that just texted, sometimes you get a transfer from the CHSLD or from a nursing home, and the family is not aware, and they panic and they send the patient to the hospital. And it doesn't mean that we need to treat them, because it can still be a level D care. So I'm not sure that always a transfer means consent to, or we should treat them.
No, so now we're talking about the specific situation where you don't have paperwork, and you don't have a level of care sign, and you don't have anything, and there's nobody to tell you what to do. Then I would assume to treat.
Yeah. Okay.
And,
yeah.
Yes, in that
okay.
But yes, in that context, to go back on the onus of finding collaterals, yes, it's on you. Because sadly, you just got stuck with the, sorry to say, but the shitty situation of having a patient you don't know much about, and you need to find out more. Maybe what I suggest is we go back to the presentation, and maybe some of these things will be covered. And if not, we'll go through these questions, okay?
And Sophie, can I ask one quick last? I want to go back to the original scenario that you gave us, where we've intubated somebody, we found a level of care that says no intubation. I have a question to you. If that patient signed that LOI form a month ago, even 6 months ago, they were compos mentis, absolutely competent to make that decision, why do you have a duty to discuss that discussion and that extubation with the family? Technically, when you make an error, you're expected to disclose it to the patient. When the patient is unwilling to, cannot accept that disclosure, we by default go to the family. But in this case, what if you were to then call the family and say, oops, didn't realize it, we intubated mom, we're going to extubate her now in keeping with her wishes, and they say, no, don't extubate her. You still have an obligation to follow the wishes of the patient, not the wishes of the family.
You do, and that's I agree with you, and that's where we fall into the tricky situation of the law. That being said, I think that in practice, while legally I agree with you, in practice, I would tend to get the family, make them aware of the situation before I extubate.
So it's simply just a courtesy to make them aware, but it's not necessarily that they now have the ability to make the decision for the patient.
Say your last sentence again.
So we do this partly out of courtesy, disclosure rules, etc. You tell them, but they do not at this point have the option to refuse the treatment that the patient has previously consented to.
Exactly. So now you'll have to explain that you'll have to take the tube out, given it was clearly discussed with the patient as documented on that date, but as a courtesy and to protect yourself. Because then legally, like, they could look at the file and say, what, he was intubated, he should not have been, he suffered, nobody told me about it. And then you're opening yourself to a can of worms. So in order to protect yourself, I would disclose to the family before extubated. If it's been, you can find no one. it's been 2 shifts. So the patient has been there intubated basically against his will for like 16 hours in the emergency room. Would it be reasonable to, once you documented that you tried to talk to somebody, take the tube out? Yes. And legally, if you were to just take the tube out and after you found the level of care saying no intubation, I don't think you would be blamed legally, but I would protect myself in terms of the family. But once again, it's not an easy situation. So that was the adult. Look, going back on what we were saying, because it's already 9:05. The adult, going back on the adult unable to make the decision on their own, that's what we just covered, okay? And yes, it can be tricky. We're going to the patient who's aged between 14 to 17 years old. So if a child refuses, and let's remind ourselves, we're in the urgent and life-threatening setting, okay? So if a child refuses healthcare in an emergency, the parents or the tutor can give the permission and go against the child's wishes, okay? So if the child, so that makes sense. Let's say the patient refuses care, the parent can just say, go ahead and give it. What if now the child and the child parents refuse treatment, but it's a life-threatening emergency? The medical staff, if there's time, can go to court or ask a judge on the phone to decide whether it's in the interest of the child to give the treatment or not, okay? So that's if you have the time. If the emergency is so serious that a court order would come too late, you as a doctor can give the child the necessary treatment, even if the child refuses and the parents and tutor refuse. So what's the perfect example of this? Jehovah's Witness, okay? Let's say that a 15-year-old female presents in the context of a traumatic hemorrhagic shock. Parents and patient tell you that the only way you will give that transfusion is over their dead body. They're very dramatic. What are your thoughts on that one? Do you transfuse or no?
I guess you kind of have to wait until the patient is in extremis, and then you'll do it. But other than that, if they are kind of stable enough, I guess you have to wait.
The patient's about to die.
If it's about to die, then you do it. Well, you ask, you start the proper steps. So you try to see if you can get the court order, but if you don't have you at least get the ball rolling. And if you don't have the answer fast enough, then you do it.
Yeah, exactly. You get the ball rolling. That's a really good point. But in that case, I would transfuse. Save that life, just document it very, very well. If you know, that's quite a common theme in my presentation. What would be the key thing to document here? I am aware that both patient and parents refuse transfusion. My medical opinion is that the transfusion was too urgent, that a court decision would have came too late. You can also document here, as Antoine said, that you tried to get the ball rolling in order to get that consent. Insert the key elements that indicate that he was hemodynamically unstable, and get a colleague on board if you can in the context. Let me check what the time is.
I'm wondering, and so this is a very intriguing presentation, and it looks like you have almost 2 parts to it. So maybe we'll do this, and then once we get past life-threatening emergencies, then we can pause there and then do a very exciting part 2 at a later
That makes
date.
sense, and we can just do a quick recap next time. Perfect. So we'll finish with still the life-threatening emergency with the patient who's less than 14. Okay, so this one is rather easy. If the child under 14 is not allowed to make health decision on their own. Okay, so the permission from the parents or tutors is always required. And it goes back, if it's impossible to get the parents or tutor consent, then you would treat. And it's a bit similar to the child who's between 14 and 17. If the decision of the parents is, let's go back to the Jehovah's Witness situation. If the child is 11 and the parents are telling you do not transfuse, you'll still do it in an emergency setting if you don't have the time to get that court order. Let me just get here. So that was the.
And Sophie, I have a question about getting rolling. Hi, I've been doing emergency medicine for a long time. And to get a court order, I don't even have the slightest idea where to go. So where do we go to get a court order? And my other comment or question is a lot of people say, get this person involved, get that person involved, get that person involved. Well, we're in an acute critical situation. We don't have time to go chasing after people. So you want to call the lawyer? Well, good. You know, it's 11 o'clock at night or 8 o'clock at night. They're not going to answer their pages, even if somebody knows they're on call. So my first question, my main one for everybody, and I don't know the answer, is if we want to get a legal judges involved, how do we do that?
So it's a good point. There should be a lawyer on call on every hospital. My experience with this, which is what I've had on CCU while trying to reach lawyers, they don't pick up the phone often from the hospital. I think this brings up a good practical point that we should have in an emergency room and easy to-do steps of how to reach a legal counsel and how you go about to contacting these people, because I agree with you, it's not easy in our situation. So to back myself up legally, I would say that I tried to call the lawyer and the situation was too urgent and I still gave the transfusion. But you bring up a good point. Any other staff or anybody wants to pitch in on that one?
But my other question is how do you get a court order from a judge at, last minute?
So there's always a judge on call. The idea is
who do you call?
Well, that's my point. Usually you'll call the lawyer of the hospital, who in that case will make your request in front of that judge who's on call 24 hours. So they could reach a judge at 2:30. I have never been put at McGill or in Quebec City, for what matters, in the situation where I had to do so. That being said, you should have a 24-hour legal counsel on call. How do you reach them from the hospital? And if people have been having an issue, that's another problem that I don't know about. But you're bringing up that practical point that we should be able to easily, and we should know how to go about on that. Yeah. Okay.
Okay. No, for me, two-step process. Contact the hospital lawyer, then who contacts the judge on call.
Yes, exactly. So you have to, I could try to, with the hospital staff, I could try to come back with you guys on that, on how you would go about to do that. I think that would be actually useful for our practice. So I can take care of that. But it is a two-step process. You're not going to call the judge yourself, the lawyer will. But bear in mind that getting a court order, when I say that, it literally means talking to a judge on a phone. It doesn't mean going into court during the day. So it's something that could be done rather quickly if you know how to. So I could get you, I'll try to get you more precision on how to do it at the hospital. Would that be fair? Okay, so I'm already 3 minutes ahead of my time, late. So next time somebody's not coming in to present, we'll do the other part of the presentation covering the rules that govern consent when the situation is not urgent, okay?
Sounds great. It was so good that I think people will be wishing someone doesn't show up next time, so you can finish off your the second part of your presentation.
Well, hopefully we can just plan it.
That would be, we can't ask for too much though, right? So, okay. So thanks, that amazing stuff from Anso, stepping up to the plate in relief. So we will move on to our next speaker, Dr. Bernard, who will be giving us a session on tracheostomy and laryngectomy. So go right ahead whenever you're ready, Dr. Bernard.
Okay, hi guys. I'm gonna just apologize in advance. I have a very little one that's gonna be probably cranky soon. It's supposed to go down for its first nap. So I apologize.
Do what you can. This is great. Yeah.
I can basically share my screen, right?
Yes, you can.
Let me see. Let's do this. Is it working? Okay, and then we're gonna get started. Do you guys hear me okay?
Yeah, we can see your screen and we can hear you.
Beautiful. Okay, so I'm gonna do like Anne-Sophie, guys. We're gonna do part 1 today. And eventually this year, we're gonna do part 2. Today, we're gonna talk about mainly tracheostomy, basically. Okay, so first of all, what is a tracheostomy? So it's an opening from the outside of your neck into your trachea, okay? It's a surgical procedure. As you can see from the picture next to it, it's much lower than a cric, okay? They usually ENT place it between the second and the third tracheal ring. And there is still a connection between the mouth and the nose to your airway. That's very important. And that's gonna be the main difference between this and a laryngectomy. A laryngectomy is complete and permanent removal of your larynx. 99% of the time, it's going to be for cancer. They're going to remove your larynx, and then they're going to go ahead and suture that trachea to the anterior part of the neck. So there is zero connection between the upper airway and your lungs. So you won't ever be able to oxygenate from above. So that we'll talk about more next time. Let's see. Oh, why can't I change? Okay. So who are the patients that have trach? So if you've gone to ICU, you might see people that need tracheostomy because they need long-term ventilation or to facilitate the weaning of it. The other big one is to maintain your airway. Okay, either they have an actual obstruction or potential obstruction, or the other big one is people that are at high risk of aspiration. Think of like stroke people, head injury, neuromuscular disorder, things like that. And the other one is either people that are on ventilator or not, that requires a lot of tracheal toilet. So severe pneumonia that you're always suctioning might be easier to get a trach, or cystic fibrosis patient might end up benefiting from that. And then in Quebec, I don't think I've ever seen somebody with that, but in the States, sometimes very severe sleep apnea could technically be an indication, but you'll never see that. Keeping that in mind, depending on the reason they had a trach, although they still have that connection from above, chances are it's going to be a challenging upper airway. So just to keep in mind. So what does it look like? Well, if you're in the ICU, it's probably going to look like this. Okay, they're connected to a vent. But many times, if they have a permanent or semi-temporary trach, they're going to eventually go home and they'll be ambulatory like this, and they won't be connected to a vent. They'll breathe room air. Sometimes they'll have a little oxygen tank at home for comfort. And you might be as happy as that little lady in that long-term care facility. Let's have a look at the tubes. There's many different kind of tubes, different size, different material, but overall, if you open a one, you're gonna have something like this. So you're gonna have always your flange or your neck plate. On that, usually you have the size of it and a lot of little characteristic about the tube. Then you have your outer cannula. You may or may not have a cuff. And if you have a cuff, then you'll have that balloon. Most tubes in Quebec have an inner cannula. So if you work in Quebec, you're always gonna have that inner cannula part. And that little thing here is called an obturator. It's when you're about to change a tube instead of that inner cannula, because it has a rounded tip. So you're gonna have less soft tissue damage. So a few little parts and characteristics that I wanna emphasize. Cuff, fenestration, inner cannula, and let's talk about the other accessories that you can see. So some tubes are cuff and some tubes aren't. It's very important if you ever want to ventilate a patient, whether you want to give non-invasive or pressure ventilation or put them on a vent, they need a cuff tube that's going to allow you to have that seal. It's going to create that like one-way passage for your ventilation. It's also going to prevent aspiration. It's also another plus. The downside from it, I would say, is that once that seal is there, if you were to provide oxygen from above, very little to none, it's going to make its way down. Okay, just to keep in mind. Someone who might not need a vent, they'll most of the time have an on-cuff tube. Okay, allow air to flow to the upper airway. It's going to sometimes help them vocalize. Then fenestration. So some tube have fenestration. It's only to allow them to speak. Sometimes the inner cannula might not have fenestration. They put in an inner cannula that has no hole, so they can easily suction. Inner cannula. If you work in Quebec, if you ever work in Quebec, you're always going to have a setup that has an inner cannula because it's much easier to clean. You don't have to remove the entire tracheostomy device. You just have to remove the inner cannula, clean it, put it back in. So for maintenance, that's a big improvement. And then you can see people sometimes that have like little caps. You'll have maybe a decannulation cap, a speaking valve, or that big thing here, like a humidifier. So you can have things that are attached to them. Now I'm going to talk about how do we change a tube, and then I'll show you a video. It's going to make a lot of sense. Yes. Always wear your full PPE. Very important because it is considered an aerosol generating procedure, any care that's related to a tracheostomy. So if you have a positive patient or an unknown status, yeah, full on PPE. Have a soft suction, gel, a syringe, 10 cc, your tube. So look on the patient's face, like neck plate, you have the size that they have. So always try to get that same size and maybe a backup one smaller. If you're not sure, rule of thumb, male a 8, female a 6. If you can't remember anything, a 6 will probably do for everyone. And if you're working somewhere, you can't find another tube to put in, a normal ET tube size 6 can do the job. So like when we do a regular intubation, you would just consent your patient, explain them what you're going to do if they're maintaining, and you're going to inflate your balloon, verify everything's working. You're going to put in your obturator that we talked about, lubricate your tube, then you deflate the other tube if it was a cough tube, and you remove it as a one-way swiping motion. And then when you insert it, you're gonna go like 90 degrees and then rotate it back in. If you're putting in a cough tube, you're always gonna have a little bit of resistance. Okay, so, and if it's an on-cough tube, it goes in super easily. Tell patient that it's normal, that they're gonna feel that you're pushing, and they will always cough. It's normal. Once you're in, remove your obturateur. If they're vent dependent, connect them on the vent, inflate your balloon. So let's just have a look at what it looks like, because it sounds very challenging, but it's not. Let's see. So here they're cleaning the site. So that's an example of a patient that's, as you can see, this lady has a tracheostomy. She's not a ventilator dependent patient. She can easily breathe through her trach, okay, at room air. So that tube that they're inserting now is fenestrated. She removes the obturateur. And then she she secures it basically to the neck. See, there's a little number here for that lady. She had a size 8, okay? So that's that. Oops, let's go back in. If you have questions, it's hard for me to see both like the chat. So we'll do question at the end, okay, guys? So what are some of the complications that you can see? So I won't go into the perioperative complication because we're not the one doing the trachs. ENT is doing that. You might see people with short-term complication, long-term complication. 7 days is kind of the number you want to keep in mind. So what are some of the complications that you see with those people? So if you have a tube in your trachea, well, sometimes it's going to get blocked from most commonly mucus plug buildup. It can be blocked from blood as well. Foreign body could also cause you to have a blockage of your tube. So that's a big complication. Then your tube can become displaced. So you can have people that are going to completely decannulate themselves. You can have a tube that's like here, partially displaced, or iatrogenic placement here of a bad cough could be an example. Then you're going to have sometimes infection anywhere from the stoma to the lungs can be infected. And sometimes it bleeds. You can have bleeding from things as trivial as local irritation, granulation tissue, infection, trauma from suctioning. But the big red flag one is going to be a tracheostomy artery fistula. What is that? When you have a tube sitting in your trachea, sometimes with time, usually 3 to 6 weeks is your kind of dangerous window, your tube may erode into that artery, which is a big branch of your aorta. So as you can imagine, that's going to bleed quite a lot. After a week, everything that we saw here can always happen. You can also be obstructed, even if you've had a trach for 3 months. All of that can happen. You can also end up with tracheomalacia. Your trachea can get a bit stenosed or dilated. Stoma can close. And sometimes they'll have tracheoesophageal fistula. I put a little star because that I could have put it under infection, basically. It's not a very big and dramatic presentation. You're going to see that in people that comes in with recurrent infection, recurrent pneumonia. That might be a cause of it. So how do we manage those people? Let's talk about the easiest one. So what if it's infected? Like any infection, guys. So you can culture it just because you have easy access to it. You can pull out some secretion, send that for culture, take a swab of the outside. But most of the time, it's going to be polymicrobial. So throw at it some nice broad spectrum antibiotics. And if you have an infection that's above, have a very low threshold to get a chest x-ray because many times they're going to go hand in hand. Now, what if your patient present critically ill, having some breathing difficulty? We're going to go over a nice little algorithm from the UK. Bear with me. It sounds very complicated, but it's not that bad. And I'll go over a summary. And after that, we'll watch a little video. So patient comes in with a trach and he's in rest distress. Right away, call for help. Get your ENT there, get anesthesia to come and give you a hand. And then you want to assess your airway. Okay, so are they grunting? Are they snoring? Is there stridor? Are they able to vocalize? Is the tube looking displaced? Is it tenting at the skin here? Is there any blood coming out? Do they look in pain? While you're doing this, you want to have someone applying oxygen both to the face and to the trachea. Because as I said earlier, most of the time they will always have that connection, whether it's a nice connection or not. Go ahead and apply oxygen to the face as well. Then you're going to remove any little cap or valve that they may have. Sometimes that's enough to remove whatever resistance you had and they'll feel better. That doesn't work. Remove the inner cannula. Sometimes that's going to be full of junk. They get better, and that was the answer. That doesn't work. Then I would go ahead and try to pass a small, soft suction catheter. And sometimes you remove some of the lower secretion and they get better. If they're still not better, then go ahead and deflate the cough. Okay. Sometimes deflating of the cough, if you have a partially displaced tube like this here, might give you enough room for air to flow from the mouth and nose into the lungs. Okay. And if that's still not working, well, you're stuck with a patient that's deteriorating, whom the tracheostomy is right now giving you no benefit. So go ahead and remove that tube. But be ready, you're gonna have to re-oxygenate that patient and secure an airway eventually. Okay. So how can you like urgency or emergency oxygenate those patients? So you can always use all the trick and trades that we have for regular patients from above, okay? You can bag, you can use adjunct, oral, nasal, airway. You can put it in LMA, but sometimes it might just be easier to just ventilate them from their stoma. You can use, if you have a nice little pediatric face mask or a small pediatric LMA, that's better. But if you don't, usually the end of your ambu bag is probably going to be about the size of your stoma. So might not be a perfect seal, but hey, better than nothing. And if that can temporize your patient and you have time for either anesthesia to show up or ENT to show up, then they might be able to re-intubate the patient from the stoma themselves under visualization, right? So if ENT has arrived and their oxygen is better, have them scope the patient. That way you might have an answer as to why they weren't doing well, and then they'll put back the tube. And if they're still not there, go ahead and put back that tube back in, okay? Same size or ET tube, okay? Or you can also intubate from above, but be mindful, it might be difficult. So let's go over that. Oh, that's an example of how you would intubate a patient from above, right? So just make sure that you go much lower than your stoma opening. Let's go over that because that was a lot of information. So oxygenate your patient, assess your airway, remove any little cap, remove your inner cannula, suction your patient, deflate the cough, then remove your outer cannula, and then be ready to oxygenate and re-obtain an airway in that patient. Actually, let's go over a video of that because that sounds super complex, but we'll watch a video. Maybe let me go back to is there any question? So you can unmute and just say something so far because I can't really see the chat. So far so good, yes?
So far so good, no questions.
Okay.
Except that the baby sounds are great. That was a note from the crowd, so.
Sorry guys. Okay, so let's see what it looks like.
You okay there, Sheila? Breathing.
Oops.
Can I have some help? Just going to pop some oxygen on for you. Hello, James. What's going on? This is Sheila. She's just struggling with her breathing. Would you be able to apply some of that oxygen to her mouth as well, please? Just a bit more oxygen, Sheila. Might help you feel better. I know she's got a speaking valve in. Will you be able to remove that and remove any inner tube please? She has got an inner tube. Okay. Would you be able to reassess the breathing there, please? Still not happy there, Barry. Could you try and pass the suction cap to them, please, James? No, that couldn't pass that. I'm going to take this tube out, Sheila. Grab an ambi bag for us, Barry.
So that's very important. So if you're gonna oxygenate from above, do some gauze and cover your trach. Okay? There we go. So sounds complicated, but if you go through the motion of it in your head a few times, it looks super intimidating because we don't see them often.
Julia?
Yeah.
A quick question. I know you said we cannot bag mask or ventilate in tracheostomy that is uncuffed. Because and it makes sense because of the risk of air leak. But I know it's maybe a trivial question, but if the patient is desanting and I don't have to change the cannula, I think I'm okay to momentarily bag mask with uncuffed trach. Does this make sense? Or?
You can. So you might not know whether the patient has a cuff or not, but what I'm saying by that is, if there's a little connector with a balloon, you know it's a cuff one. If you have one that's uncuffed in place and you still want to give some oxygen, you can. It's just that it's going to probably follow the path of least resistance. So if you have a blockage lower, it's probably going to end up going through the mouth and nose. You can try it. There's no harm to it. It just might not be not as efficient as if you had a cuff one. Am I making sense?
Perfect. No, it makes sense. Thank you very much.
Okay. Let's now talk about a patient, for example, that shows up and that has lost this tube. Okay. So let's say they accidentally decannulated themselves. First question you're going to ask yourself is, when was the tube done? Very rarely you're going to have somebody show up within the first week of it because they're usually still in hospital and their neck plate is actually suture in place. So that shouldn't happen. But in the rare event that you see somebody with a fresh trach and it came out, the patient is not in distress, you have two options. Chances are I would probably just wait for ENT to come down and re-put one in under direct visualization. I wouldn't myself go ahead and put one blindly if my patient is stable enough. And otherwise I would, and if you have no ENT wherever you work or whatever, then you're gonna have no choice but to go from above. If it's been more than a week and it's in place, I would have no trouble, no concern about creating a fast passage and going directly in the trach. Then you have to ask yourself, how long has the tube been out? It's not going to close within a minute. Okay, people, they get their tracheostomy changed every other few weeks. Okay, so when it's out, you have time. It's not going to close within a minute, but if it's been out for, I don't know, half a day or something, then maybe you're going to have to think about adjusting the size. If you want to be super cautious, go ahead, use a soft short bougie or tube exchanger to go in first, see if you can easily pass that in and then put in a tube. Now, let's talk about bleeding.
Dr. Bernard,
yes.
I just want to make sure that the librarian has a bit of time to speak after.
Yeah, 1 minute and I'm done. Yeah,
okay.
Perfect. So what if it's bleeding? Even if you're bleeding just a little bit, keep in mind, it can still be a tracheoinnominate fistula because 50% of them will show up with a very small sentinel bleed. Okay, so keep that in the back of your mind. Look where the bleeding is from. If it's bleeding around the stoma and you see, for example, sometimes you lift up the neck plate a little bit and you see a little bit of granulation tissue that's bleeding, cauterize it with silver nitrate. If it's really at the entrance between the neck plate and the stoma, you can pack it with a little bit of gauze or even a mesh with tranexamic acid. But whatever you do, don't put anything that can fall, obviously, into your trachea and block your airway. Get ENT to come, have them assess where the bleeding is from. If you have blood in the lumen of the tube, small amount, 10 cc's, whatever, suction that airway, and then get ENT to come and assess where the bleeding is from. They're stable. It's a small amount of time of blood, so you have time. Sometimes it's just the stoma that's bleeding inside their airway. They're coughing it up and it comes out in the lumen. Or sometimes it's hemoptysis, actually. So it might just be the lungs. Lastly, what if it's bleeding quite a bit? So last thing I'm talking about, and then you go with the librarian. So call for help. You want to call ENT and they need to go to the OR. So you need a thoracic surgeon. Suction that airway, so suction that tracheostomy. Then 85% of the time, just overinflating your cough, if you have a cough trach, is going to do the trick. So overinflate up to 50 cc's very slowly. That should temporize the bleeding. If that doesn't work, you can always withdraw the tube a bit while applying like external pressure. And the most advanced thing, then I would say intubate from above, remove your tube, and get someone to put in a finger in that tracheostomy hole and go ahead and push on that artery against the tracheal notch. Keep in mind, guys, this is like rescue maneuver. It is a super rare event. Hopefully, you will never encounter that in your entire life. But if you do have a patient that's bleeding out, you'll have like the step in your mind. Super fatal, and they need to go to the OR. So if you are at that step where you have to put in a finger in that hole until they make it to the OR, that might be what saved their life. That's it. Next time we'll talk about laryngectomy, where you don't have a connection to your upper airway. And that's it. Any questions? Yes.
That was fantastic. Both you and the other child sounds that were being played in the background. It was great. Added some context to airway difficulties. So thank you very much.
Thanks,
all right.
guys.
So as per what we discussed earlier on this year, Dr. Lars Grant really wants to incorporate research methods and discussions into our rounds. So we're very lucky to have a McGill librarian, Amy Bergeron, here to discuss systematic review and library resources. So thank you so much for being here, Amy, and go ahead.
Yeah, thank you so much. It's my pleasure. So hi, everyone. First of all, I usually work at the Glen site. I'm actually an MUHC librarian. So I'm going to talk about this, us versus McGill. Don't worry about it. It's a really common mix-up that we hear all the time. It's perfectly okay. So the MUHC libraries are on multiple sites. We're at the Glen, the General, the Neuro, and we have kind of satellites elsewhere as well, but we're all working from home. However, you can absolutely reach us. So today, I'm just going to dive right into the slides, actually. Here we are. So indeed, we're not talking about something clinical. My expertise is not the clinical side of things. That is your domain. I'm going to be talking to you rather about the research side of things. So in addition to systematic reviews, there are other kinds of knowledge synthesis. I'm going to be kind of going with broad strokes today. My hope is basically to cover just a few things. So we're going to talk about what is knowledge synthesis, systematic reviews. What else does this include? We're going to talk about what kind of support the libraries offer. And then we're going to do a little bit of hands-on stuff. We have a little bit of time to look at protocol development, which is really such an essential first step. So for those of you who are just learning about knowledge synthesis, maybe you've never worked on a systematic or scoping review team, this will be a bit of an introduction for you. However, if you have something in mind that you would like to actually work on as a project, think about that as I'm talking, because during the demo, you'll be able to maybe put some of this into action to start planning a review. Okay, so the Canadian Institutes of Health Research have a really specific definition of what knowledge synthesis is, which I won't read. Probably you know that knowledge synthesis is essentially an analysis of pre-existing medical literature to put things together for better evidence, to pool different types of findings and so on. So you'll know them as systematic or scoping reviews. There are other types of knowledge synthesis as well, such as rapid reviews and umbrella reviews and things like that. There's, you know, many, many genres, but essentially we're talking about, again, something that will review existing literature to create new knowledge, ideally. And so we're going to talk, first of all, about where we fit in, and I'm going to give you a bit of context about what we do broadly. So McGill Library and MUHC libraries are distinct. Of course, McGill University and the MUHC are very close together institutionally, but we're distinct. So we do work with McGill librarians, and in fact, you know, everyone here present has access to both. So this is, we share, you know, a huge part of our communities. Essentially, you can come to us if you're doing anything in terms of clinical or research work that pertains to MUHC stuff. And then you can go to McGill for extra assistance if you're doing something for your own academic projects, or if you're teaching and you need assistance, maybe you want to search on, you know, educational methods for graduate medicine or, you know, whatever that is. If ever you're confused, you can contact either one and we will tell you where to go. And so again, I'm affiliated with the MUHC libraries. This is our website. I'm going to come back and give you my email address and our general email address at the end, so you can get in touch, but just so you know about this distinction. So the libraries broadly do a bunch of different things. So we offer point of care tools, we give general information. We also work on different types of research projects and lit reviews. And we offer knowledge synthesis. So again, I'll just kind of go through this broadly because it does tie in very much to the steps that go into knowledge synthesis, because it really encompasses all of these other things as well. So in terms of databases, we will teach and select. When you come to us for a project, we will help with database selection because there's different coverage. A lot of people know Medline, also known as PubMed. It's just a different interface. Embase is largely European. It's an essential one for anything to do with pharmacology, but also a lot of like midwifery, certain types of dermatology. There are just strong points in Embase as well. There's the Cochrane Library that you probably know about, which will have lots of RCTs as well as a review of systematic reviews, or a library rather, of systematic reviews. Web of Science and Scopus are both multidisciplinary citation tracking databases, really useful when we're doing this kind of in-depth methodologically rigorous work. PsycInfo is also used sometimes, might be a little bit less relevant for emergency medicine, but one never knows, right? Because there are many, many things you could be doing. So in addition to this kind of, you know, advisory stuff, we also teach workshops. So if you are interested in doing a knowledge synthesis project, I would strongly recommend that you come to our Medline as well as our EndNote workshops, because these are the places where you're going to actually learn some of these skills that you'll need to effectively go about your workflow and develop what you need for your project. However, we also offer a searching service. So at the libraries, you can come to us, not just for big knowledge synthesis projects, but also for just a handful of articles or to prepare for a presentation or what have you. And we search the databases, we send you the results, and we can give assistance about making sense of that sort of thing. So then coming to knowledge synthesis. Scoping and systematic reviews are different, right? Because methodologically, they're supposed to be as robust as possible in the sense of being bias-free, being transparent, and being replicable. So there are a number of methodological steps that these types of projects have to go to that you don't have to do with like a normal, you know, narrative lit review or something like that. So part of that is planning a protocol, which is the map that commits you in advance to doing things in a certain way, looking at certain sources for certain types of information and analyzing it in a certain manner. And there's also the fact that you'll have multiple people screening. You always need at least 2 people for a knowledge synthesis project. We strongly recommend having more than 2 people, but that's the minimum. You cannot do this kind of project on your own. And additionally, you'll have some additional, like, you know, this extra work to do at the analysis level, though that can really depend if you're doing scoping versus systematic reviews. We're going to talk a bit about the differences. So here I've sort of mapped out where the librarian team actually gets involved. So I will say that we're actually switching models right now. We are in the process of rebuilding our website and launching a new application form to have us collaborate on these types of projects. So if you're interested in that, watch our website, or you can get in touch with me. But you won't see everything on our website just yet because we are finalizing a long process of replanning our service. But essentially, we like to get involved quite early in the planning phase. So we're going to talk about your team composition. We'll ask you about various roles and experience of your team members. Protocol development is really huge. And another step that you may or may not know about is existing literature, checking whether things are published, but also checking if there are review protocols that have been registered. This is partly to lay claim to your research, to get credit for what you're doing, but we've also actually had cases at the MUHC where my colleague was contacted by a team who had a really great idea. And of course, she went through the steps of checking for them, I think on Prospero, if there was another systematic review already underway. I don't recall the topic, but it turned out there was another team actually at the MUHC doing pretty much the same project. And so she ended up referring them, so they just got a larger team. So I can't promise that that'll happen, but sometimes it does. Anyway, retrieval is where I think teams know, if they know anything about what libraries offer, they're aware that this is really where we can shine and help out and basically give you a lot of the deliverables more than consultation. So we do offer a service where we will develop the entire search strategy. It goes through peer review on our end to make sure it's quite complete. We translate to other databases, and then we give you the results in a deduplicated library. At the level of analysis, it's usually the team that will do all of that, but sometimes we'll offer guidance and resources for data extraction and risk of bias assessment. And then at the level of writing, we are co-authors in this process when we're doing this full package rather than just consultation. So we will prepare the relevant part of the methods section. We'll help with, the abstract and any indexing depending on the journal, and we'll ensure that it conforms to PRISMA standards. And so one of the big benefits of this is that when we go through this full package formal collaboration process, when you're submitting to your publication of choice, we can more or less guarantee that you will not be rejected for methodological reasons pertaining to the search, because this can be a concern. So from the very first meeting and the intake level and protocol development, we're really focused on making sure that everything is quite consistent, well documented, so that at that level, you will have that confidence. Okay, so I've kind of covered this already, but we offer a number of deliverables here, and the requirements are maybe of more interest for you. So the principal investigator should usually be an attending physician. We definitely work with lots and lots of residents and fellows. It's possible to have a stable PI that we would consider also eligible, but typically you want to have a full-time attending on your team. The rationale for the project. So this will include, what is the nature of the issue? Why is this of interest? Where is this going? And justifying if there's already been a review on this, it was too long ago to be relevant, or there's this review, but it's on a different angle, something like that, because we want to minimize overlap and duplication of research efforts. The other big thing is that you have to have a draft protocol ready, which again, we're going to come back and talk about a little bit. The timeline from beginning to when you get the actual deliverables, the results from us, is 2 to 4 months. And the librarian, as I mentioned, will be a co-author of the published review. So now we're going to get into talking about some of these specific methodological issues and a little bit of this hands-on protocol stuff. Just checking the time. Great. So scoping reviews versus systematic reviews is a much broader subject than is really within the scope of what we're going to do today. But the McGill libraries, I believe, do offer workshops semi-regularly on the differences and how to tell whether your topic idea is one or the other. Very broadly, a systematic review will answer quite a specific, narrow clinical question that can be quantifiable in some way, whereas scoping reviews answer slightly broader or exploratory questions. So you might have, a systematic review on the efficiency of, class X of medication for, Y disease, whereas a scoping review, that I've done, for example, was on different types of actigraphy, monitoring and fitness devices, and the diabetic population or something. So that isn't answering a specific question, it's exploring all the literature. But both of them are going to try to be quite broad and comprehensive and get all the published literature in an unbiased way to really get that correct snapshot of what is the state of knowledge at this time. Okay, so that being said, scoping reviews are newer. So if you've only heard of systematic, if scoping is newer to you, that's totally normal. They've been around for quite a long time, but it's only in the 2010s that we kind of got more of a consensus in the form of the Joanna Briggs Institute has now a chapter on scoping reviews in their knowledge synthesis guide. So this manual is a huge text that we refer to quite a lot. They also have a protocol template that I can send to folks if you're interested. And the protocol itself can be published on the Open Science Framework. I think it was in 2016, if I'm not mistaken, that the manual was first published. So it's still kind of a growing area. Methodologically, things are pretty consistent, I would say now, but it's kind of a new service that we offer in addition to being new to a lot of teams. So keep that in mind. More likely, you've already heard of these and might be more excited about systematic reviews. So we've had formal guidance on that for much longer. So the Cochrane collaboration, but also the Joanna Briggs Institute, the Campbell collaboration, Prisma, and so on, offer different types of guidance because there are different types of systematic reviews, which again, we won't get into today. Typically, folks will register on Prospero, and that is basically a database of protocols for systematic reviews. So again, we have folks search there before starting a project where we assist with that. And this kind of gives a structure when you're registering on Prospero that essentially creates for you a protocol. So across these specific types of publications, they always are going to have a rationale for the project, details about team composition, the inclusion and exclusion criteria for when you're actually screening, what will you count as essential to be in the title abstract usually for it to be relevant enough, and a preliminary search strategy. This is the last real slide before we dive into the demo stuff. And just keep in mind that you don't have to have the full final version to start the project at all. But at least you want to start thinking, again, if this is on your mind at all, create a Google Doc right now and just start planning out some of this, or look at these templates and start taking notes, because this is really worth doing well. We've seen many, many, many protocols at the library that needed a lot of help before the team could get started. And we've done various degrees of letting it slide versus requiring higher levels of conformity to best practice. And I can guarantee you that you will have an easier time if you have a strong, robust protocol. Okay, I'm gonna just share my different screen because I think that was only a slides. All right, so we're gonna toggle out here. Do folks see PubMed instead? Yes, good.
Yes.
Excellent. So this was quite broad level abstract. For just a couple of minutes, I want to talk about how you would get started with your protocol, looking at the search strategy. So really, really broadly, I wrote down some topics that you could be interested in just to do a little sample. Let's talk about long COVID. It's not necessarily an emergency medicine thing, though it could be. We're seeing lots of inquiries from different types of groups. So long COVID, of course, is having chronic or recurrent symptoms. The language is still quite heterogeneous. You'll see there are only 577 results. And COVID research is quite a hot topic right now. So let's say that you go ahead and just type something into PubMed. Again, this is assuming you haven't taken workshops with us. You don't have to be an expert searcher to start this. So I'm really demonstrating this in as simple a way as possible. You'll go through and you might have something a lot more complex that you would want to put into there. But I would recommend looking for the first 5 articles that seem really relevant to you. And you're going to start keeping track of the terms used. Oops, here we go. I have a connector device that's trying to get me full text, which I don't need. All right, I have opened 6. So one thing to note is that here we are. Here on the side, if there are mesh terms, which is medical subject headings, it's what we use to retrieve and index medical literature. New articles don't have mesh. All this to say, what we're going to be doing is largely collecting mesh and keywords. So again, if you don't quite follow what the implications are of having mesh versus keywords, please do come talk to me or come to one of our workshops. Yeah, these are all new, and it's my fault for choosing COVID, but hypothetically, you would come here and you would jump down to get at some mesh. Let's do another one just so you can see. Sure. Perfect, and then I'm going to go back in time. And I'm doing that because newer articles often are not indexed, which means they don't have mesh subject headings applied. So I'll open a few here with the hopes that from 2016, they'll be old enough to be indexed. Yeah, so this is what you're looking for here. So you'll come, look at the mesh terms, and you again want to look at least 5, 10, maybe even more. This one doesn't, that's okay. And you're going to compare them. And it can be quite interesting when you have multiple things on the same subject, but that are using different terms. And honestly, you can just save these with the URL in a Word document or in a Google document. I actually really like working in Excel, so you can set something up like this with wide columns. So you'll have your concepts and searches, but if that's complex for you, you can simply start tracking these. And this is the first thing that we're going to look at when you submit this to the library. This allows us to start brainstorming about that search strategy because we use both subject headings and keywords. And despite the fact that we would like to pretend that there are standard ways to express things all the time, it's not always the case. Different authors use different language. So there we are. That's kind of a very, very quick introduction to finding the initial mesh terms, and look at those abstracts, take note of the mesh terms, take note of any keywords. Keep in mind that in different countries, people express things differently. Sometimes there's older or newer language used. Okay, this is all we have time for today. I don't want to take up the next person, but you can get in touch with us, either Google MUHC libraries, or you can contact us at the general address is now through our Glenn inbox, or you can contact me directly, or again, you can Google Amy MUHC libraries and you will find me. I would love to talk a bit more about this and help you with your specific projects. And I will just show you finally on our website where you can sign up for classes. So here we go, training and guides, upcoming classes and workshops. And this is where you can find information about registering. But we also offer one-to-one workshops. So if ever the times don't work for you, don't be shy to get in touch. So I'll leave that there. Do folks have questions? Lightning round. All right, well, thank you.
I was wondering if that website that you just went to with the workshops, could you maybe copy that link into the chat, just so then if people are interested, they can take a look.
Sure. Yeah.
And no rush, we actually have a break coming up. So if you have more that you would like to say, that's not pressure, but you can go ahead and say it.
Okay.
if we cut you off early, yeah, because we have a 15-minute break, but we started a bit late, so we can easily extend by 5 minutes.
Okay, yes, I will go ahead. Yeah. Yes, I hate feeling rushed. All right, well, for those of you who just want to go on break, that's fine. If you do feel excited about this, then stick around. All right, I'm going to go dive back in then. Okay, so I would really like to be able to show you a little bit more concretely what this workflow is. Okay, so we have realized that mesh and long COVID are not friends yet. However, there are mesh terms that are applicable, keep in mind. But what I would do, here we are, we'll start a different one. Let's talk about evaluating testicular torsion. Okay, there we go. This is more of an obvious emergency question. This on its own, of course, isn't enough to make a systematic review with, but I'm showing you with one concept. Often, if you're interested in doing a big knowledge synthesis project, right, you're looking at least 2 variables. A lot of protocol templates will have you structure things with PICO. Everyone knows PICO, so that can be quite good for brainstorming, for figuring out what your searchable concepts are. But yeah, we're just going to do this with one thing at a time so you can see what is really going on. And we talk in our workshops quite a bit about mapping out what the searchable concepts of your question are. Sometimes it's obvious, sometimes it's less obvious. As one example, I'm doing a search right now on aggression, managing aggression and disruptive behavior in non-psychiatric emergency contexts. So on its own, for example, like emergence like post anesthesia aggression may or may not be lumped together with this concept of aggression. And that would really depend on, like, is the etiology relevant? What are the treatment factors? What are you actually looking for? So one concept on its own, usually you'll have the kind of pure version of the concept, but then often you'll discover these layers around it that are logically equivalent for the sake of your search. So that's something to keep in mind. This explains partly why it's important to take note of different mesh terms. There are often really, really different mesh terms for different facets of a disease. And so anyway, you want to shop around. So let's just have a look at how we would do this. All right. And again, some of these are going to be newer, 2021. So I'll just take a couple of new ones and then we'll again jump back in time a little bit. So if you don't know, basically the process for indexing, which is adding these mesh terms, is that a human being reads each and every article, a subject expert and or librarian, and they will manually assign these subject headings. So there is a delay from when things are published. And often it's, you know, at any given time, I think something like 10 to 20% of articles don't have indexing. So this means that it's essential to use both mesh and keywords when we're doing comprehensive searches, because, you know, both these articles I would not find if I was using only mesh. You want to really be comprehensive. All right. I did open a few older ones too. So we're going to come down here again. Good, wonderful. You'll notice I didn't even really look at the abstract for keywords. We're just going to keep it simple. So here we go. All right, so this tells me right away, without even having to do any complicated browsing directly in the mesh vocabulary, let's just say I don't really know much about it, I can come right here and I'll see, all right, so spermatic cord torsion is, you know, technically what it's called. Oh, here we go. I don't need this anymore. So I'm just gonna paste that into a notepad document for now. Keep it really simple. Come here, yes, we see the same thing. And we should see the same thing here, yes. However, you'll also notice that we have these backslashes with extra words. These are subheadings. You don't need to worry about that. And then from looking at a few different things, you might realize that you have some other interest, you know, orchiectomy or whatever it is. But essentially for the cord torsion, we see that there's basically one term, that's fine. You'll see these other interesting related ones though. So again, depending on the nature of what you're looking at and the project rationale, you could consider quite a few other terms from here. So just for the sake of being exploratory, I'll come put these in here as well. I won't bother taking this off right now just to show you, but you can mentally do that. So what I recommend, again, this is assuming you don't have a lot of searching experience, you just want to start making some of those little notes for a project. It can be very nice to simply have something in Excel where you're just going to put notes. So you don't have to know how to actually use them in the database. You don't have to worry about syntax or anything else like that. This is just to plan out so that your searcher will have an easier time. So let's say concept one is testicular torsion. So I have some mesh terms here, and then I'm also going to list my keywords to make sure that I'm also retrieving literature that is new. So I'm going to start with concept two. Sure, we're going to talk orchiectomy, just because that came up here. So again, I'm going to go concept by concept just to build that initial framework. And you can kind of get the idea. I would adjust for the dates. I would pull out any mesh terms. And then finally, once you've done this preliminary thing, so I've created 4 columns here. Sometimes your review will only have 1 or 2 concepts. Usually there's some kind of restraint, but sometimes it'll be quite a bit more specific, which is perfectly fine. The next step that can be really good to do, which we would get to a little bit more in workshops, is the top-down way. So this is basically the bottom-up way to find mesh terms, to look at the actual published literature, look at your target articles, collect some of that stuff, and then take notes of these things. So then the other way is to go from the vocabulary itself. So again, we talk about this more in our workshops, but you can just Google mesh browser and you'll come to this page. There are a lot of ways to actually access medical subject headings and find ones, but this is my favorite interface. It's nice and organized. Note that by default, it's going to be on exact match. Please turn it to any fragment because you won't necessarily know right away. So as an illustration of what I was saying about multiple mesh terms often being relevant for a search, I'll just show you this, depression. So once I've already looked at these articles, I will again search my concept. Let's just say we were looking at depression to make sure I haven't missed anything from mesh. So this is something we teach because this trips people up a lot. Depression within mesh is the depressive state, but it's not the mood disorder. So often people will look for this, they'll find this first and they'll say, great, yes, that's my topic, depression, without realizing the specific scope of meaning. Mesh is organized hierarchically in a tree. So you see these are the parent concepts, and depression falls under behavior and behavioral mechanisms. Whereas if I come here to depressive disorder, I'll see the scope note says that it is an affective disorder, etc. It'll give me some other information here. And in the tree, I can see it's under mental disorders, mood disorders. So I really can't emphasize enough how important it is to go through this. You'll see these other types of depression, but when I open it up, and this is why I like this interface, you can go quickly through the tabs. Here we are. You'll see that it falls under something else.
We probably will start to close it up. So.
Yes, okay, that's fine.
Thanks.
I'm just having fun at this point. Anyway,
yeah.
Collect your mesh terms and contact a librarian. That's my conclusion. So to get started, you can do it and contact us for more.
Awesome. That was great. Thanks so much for not only the initial lecture, but the demos as well. So thanks so much for taking time out of your day to come join us.
Absolutely. Feel free to get in touch.
Perfect. Thank you. All right. So we will take a break here. I think that it will take 9 minutes now. We'll come back at 10:20. Okay, and then Tanish can get going on his presentation that has a very tasty title.
Let me know whenever I'm good to get started.
Sounds great.
Was that sounds great? That I'm good to get started, or that it sounds great? You let me know.
Sorry. I was just sitting down when I heard get started, so I said sounds great, but there's more to that sentence then. Okay, so yeah, please, absolutely. Sounds fantastic. Get started. Thanks, Dinesh.
Hey everyone, I'm Dinesh. I'm one of the third year CCF PEM residents. Today my CAT critical appraisal topic is going to be on this paper called SALSA and SALT. And just give me 1 second. I'm going to hide all the videos so I don't have to see my own face because I am currently post-call. So if you're thinking, wow, this guy's kind of ugly, please cut me some slack. Coming up for 5 nights of ICU. So
we're trying to withhold from these comments. It's going to be hard.
It's okay. Just keep it to yourself or in private chat messages. Not to me. So the agenda for today, we're going to talk about some relevant cases and background relevant to my topic, and then we'll talk about hyponatremia, which is everyone's favorite topic. We'll talk a bit about hypertonic saline and then the SALSA trial, and then we'll finish with some takeaways. So since it is critical appraisal, just a few things. These are kind of the 3 sources that I ended up picking on my content from. So background-wise, I informed it primarily off of our routine texts, so symptomalities, erosions, and then some FOMED sources. Treatment-wise, I based it off of international guidelines. And then the PICO and CAT question is going to be based upon the SALSA RCT. It took me a while to get to this RCT. There was a few other ones that I really wanted to do. The targeted temperature management was one of them, which I was going to call, is it chill to be cool? And then there's a COPD and pulmonary embolism one, which I was going to call putting the PE in COPDE. But in the end, my love for food prevailed. And so I ended up with the SALSA. So some relevant cases. I'll read them out, and it's just something to get people thinking about like what they would do to get an idea and contextualize some of the things we'll be talking about. So this is the first case. It's a 42-year-old guy who has nausea and headache. He had a weekend of partying, lots of alcohol, ecstasy for the first time at 42 years old. And he appears well. He's got normal vitals, no signs of any fluid overload or depletion clinically, but his sodium returns reasonably low, 124. And his last known sodium is about 136 from 2 months ago. So you panic and you wonder, do you need to rapidly correct this guy's sodium with hypertonic saline, or what's your management strategy going to be? Second case is going to be an older lady, 66-year-old, who comes in with heart failure, shortness of breath while lying flat, worsening pitting edema, kind of a classic picture. You do a little bit of a workup and you decide that she has a CHF exacerbation. And so you just have to treat her with some Lasix. Lab work comes back a little bit later and her sodium is 116. And now you're thinking, oh man, this person is pretty hyponatremic. I really hope that I haven't overcorrected their sodium. And what is their best treatment option? How should we treat the sodium of 116? And the third case, final case, is going to be the 72-year-old female. Presents to your emerge after being found drowsy. And last time she was seen is not super clear, but she's found drowsy at home. Recently switched to a thiazide diuretic for her blood pressure management. And she appears well, actually, other than the fact that she is confused with a GCS of 10. So she is protecting her airway. Her serum sodium comes back at 121. So you wonder, okay, I feel like I need to give this person hypertonic saline. It seems pretty low. They're altered, but how do I avoid overcorrection and what should I really be doing for that? So those are the cases. Let's delve into a bit of a review of hyponatremia. And we'll talk about it briefly in terms of pathophysiology, but the emphasis is really going to be more on treatment today. This isn't going to be your typical, there'll be a little bit of it, but we're not going to go into the depth of your typical internal medicine hyponatremia lecture. Just a bit of basics though. Hyponatremia defined based upon your lab assay. I have a few different numbers. I've seen 133 here, but around less than 138 to 142 is considered normal range. So they'll define it in 3 categories. Your 130 to 135, 138 is considered mild hyponatremia. Your moderate is typically within the 120s, and then below that's considered severe by numbers. As a whole, it's the idea of hyponatremia is you have an excess of water to sodium. And so that doesn't necessarily mean you have more water in your body. You could be euvolemic, you could be hypervolemic, you could be hypovolemic. And so there's many ways to classify it. It's either by the osmolarity in your blood, your volume status, how dependent you are and how appropriately dependent you are on ADH, And then the chronicity, about 48 hours is used as your acute versus chronic cutoff, because that's usually the time that's required for your body to adapt to changes in sodium. This is it's kind of your common flow chart you'll see. So you see a sodium that's low. First thing you should think about is this hyponatremia or is this pseudohyponatremia? And pseudohyponatremia typically occurs in hyperosmolar states. So there's a higher amount of effective osmoles in your blood through things like mannitol, sugars in the DKA. That's going to bring more fluid into your circulation. And that's going to increase the overall fluid, reduce the relative amount of sodium, and that can cause this pseudohyponatremia, where sodium levels are actually fine, but due to these effective osmoles, you have a decrease in what's measured of sodium. If it's not an increased osmolarity, then you have true hyponatremia, and then you're going to base your differential based upon the patient's urine osmolarity. And this is not necessarily something we'll always get into the emerge, but typically what we're looking at with the osmolarity is how appropriately is this patient excreting water. So if they're excreting water appropriately, typically we think it's something along the lines of too much water intake. And there's nothing wrong with that kind of ADH system. On the other side, if there's impaired water excretion, then you're thinking things based upon their fluid status. Either they have a lot of extrarenal losses or diuretic use, or they have euvolemic symptoms in SIADH for some reason, or they're hypervolemic and they have things like cirrhosis or CHF or renal failure. Just to kind of contextualize other things, to think about what patients should we really be thinking about this in. Your causes of SIADH from tendinales is kind of outlined here pretty nicely. And really the idea behind it is that your urine osmolarity is inappropriately elevated. You'd expect it to go to be reduced in a setting when someone has too much fluid. So this is kind of an inappropriate level of increased urine osmolarity. And so in this setting, there's a few things that can cause it. You think about your neurological and psychiatric disorders, and then you think about drugs. So lots of different drugs you may have heard of, but things like amiodarone we commonly use. SSRIs can often cause it, narcotics as well. And then thinking about your classic things you hear about, like ectopic production of vasopressin from carcinoma of the lung or lymphoma, and then your infections in the lung of tuberculosis and things like that. There we go. So your overall treatments, and we're going to go way more into depth of this afterwards, but your overall treatments are going to be guided by a few things. You don't purely guide your treatment based upon the number for sodium itself, because that alone is not enough to tell you how severe this patient is. Like someone can have a really low number for their sodium, but have no symptoms and have it chronic, in which case the treatment is going to be different. Or they could have what doesn't seem like as low of a number, but acute and then change in their neurostatus, in which case you're going to treat it very differently. But your options are going to be based upon a few things. It's going to be based upon their fluid status. So if they're overloaded, you're going to use Lasix. You're going to keep them NPO with fluid restriction. If they're hypovolemic, you're often thinking of using IV fluids. And then in another situation, so that's ADH, you're going to treat the underlying cause. So if they have a lung tumor that's causing this or a medication, you're going to try to address that. And then in really emergent situations, you're going to use things like hypertonic saline. And the reason why it's not as straightforward, like everyone with hyponatremia is going to give hypertonic saline so they can go home with their charts checked nicely with a nice sodium value. The reason we don't do that for everybody is because really in the end, as with many things, this treatment is not benign, right? On one end, if you have hyponatremia, it can cause cerebral edema, and it can cause seizures, coma, death. It can cause swelling of the brain, and leads to all these neurological symptoms. On the other hand, if you do increase sodium too rapidly, especially in a patient with chronic hyponatremia, you can cause osmotic demyelination syndrome or central pontine myelinolysis, or whatever term you want to use for it, but you can cause that. And that can lead to permanent neurologic disabilities, such as dysarthria, dysphagia, things like that, even death and coma. So this is a real thing to be concerned about, and a real reason why we have to be very judicious with how we treat patients when they do have hyponatremia. And we have to have while there's no universally agreed upon approach to it, we have to have an idea of what negatives and positives we're going to balance. So how do we decide on treatment? Well, there's a few guidelines that came up in my review of the literature. The European guidelines, there's kind of two major ones that came up when I was reviewing through the RCT I was looking at, as well as kind of the literature on hyponatremia in the last few years. There's a European guideline and there's a North American guideline. And so this European guideline, what they say is that for anyone with severe symptoms, and they define their severe and moderately severe categories here in the bottom right, anyone with severe symptoms is going to get 3% normal saline regardless of the chronicity, because in those situations, the concern is cerebral edema and you need to reverse it. If you have moderately severe symptoms, those ones above it, you consider a few things. You consider the patient has had more than a 10-point drop in their sodium levels. They don't define over how long, so they don't have a reasonable time for how long you actually expect a 10-point drop. But ideally, it would be like you have a recent sodium that's not like years old or anything like that, and you notice a 10-point drop. So in those situations, you can consider 3% normal saline. Otherwise, you just assume it's chronic and you identify a cause, and you try to treat it by reversing the cause and giving fluids or Lasix or whatever is relevant based upon those things I showed earlier, and treating it that way. The other two situations, in an asymptomatic patient, you're going to treat their cause and you're going to monitor their sodium, so no hypertonic saline. And then in chronic as well, they also suggest treat the specific cause, no hypertonic saline if there's no severe symptoms. This is contrasted to the American guidelines, which I would say overall is pretty similar. It's just the emphasis is a bit different. In the American guidelines, put a bit more emphasis on acute versus chronic. And so anyone acute, they say you treat with severe symptoms. And they don't actually define what severe symptoms are, but I think it's safe. They say the severe symptoms are ones that are suggestive of cerebral edema, so things like coma, seizures, etc. And they suggest an increase of about 4 to 6 millimoles per liter of an increase in sodium, because that's how much they expect is required to actually see an improvement of these symptoms. The patients with chronic hyponatremia, and if you don't know if it's acute or chronic, you assume it's chronic. You do the stratification approach where you decide are they low or high risk for osmotic demyelination syndrome. And table 3 in the bottom right there, they show kind of the risk factors that would make someone higher risk for osmotic demyelination syndrome. And so in those situations, if they're low risk, you try to correct them at least 4 to 8 millimoles per liter per day, and you go to a max of 10 to 12. And really, there's no benefit of going 10 to 12 versus around 8, because at that point, really all you're doing is you're increasing their risk of osmotic demyelination syndrome. And when 4 to 6 is really all you're required to reverse symptoms, it's usually recommended to go closer to that 4 to 8 range. And then in a high-risk patient, you actually go 4 to 6 and you keep a max of 8. Now, in a severe patient with chronic hyponatremia, you're going to meet those numbers in 1 to 6 hours rather than in 24 hours. And then the rest of the day, you kind of keep them stagnant at the same amount of sodium. So this is the other one that I found that's, and so just kind of for context, Rosens, for those who use Rosens, are going to find that it's going to be very similar to the American guidelines. I think they actually based their treatment patterns off of the North American guidelines. And then Tintinelli's, this is the chart from there. And they kind of suggest kind of a blend of the two. They actually reference both the European and the US guidelines. And so what they suggest is that in severe symptoms, you give them hypertonic saline. They suggest 100 mLs, which we'll talk about later on, because that's kind of, I was a bit iffy on that. And then they also suggest this 4 to 6 milliequivalent per liter range. So let's come back to the cases quickly. And then what we're going to do is we're going to start to talk a bit more about hypertonic saline and the SALSA trial. So the first one that we saw is the 42-year-old who was trying ecstasy and comes in with that sodium of 124. So the way I would characterize him in my head is I would call him a 42-year-old gentleman with likely acute hyponatremia with moderate symptoms. And so I use that based upon the European definitions of what they call moderate versus severe symptoms. He's got nausea and headache, but he's got no vomiting. He's got no altered mental status. His vitals are fine as well. He does have a 10-point drop in his sodium, 136 to 124, but this is a bit iffy because we don't really get a time frame for 2 months, like whether that fits within what the European guidelines would suggest or not. So in this situation, it is debatable what you would do. I think some would treat with hypertonic saline, and I don't think you'd be faulted for it. And then some would trial fluid restriction and try to reverse what's likely SIADH from the ecstasy this patient tried. So that's how I think about this first one. And as you can see, there's no clear-cut answer. And we'll come back to this a little bit later afterwards. The second case is going to be this 66-year-old who has heart failure that presents with a pretty severe number for their hyponatremia, 116. They don't have any symptoms of moderate or severe symptoms of hyponatremia. And so in this situation, what you're going to do is you're not going to give them hypertonic saline because they're a patient with chronic hyponatremia without symptoms. And overall, I'd say they're lower risk for ODS. They don't have cirrhosis, they don't have those things. The age debate is a little bit of a risk, but in this situation, we'll call them lower risk. And so you can go up to 10 to 12 millimoles per liter per day in terms of your increase of sodium. Realistically, I think most people would keep it closer to 6 to 8. And they would achieve this by treating them with Lasix. And then case 3, the 72-year-old with hyponatremia and severe symptoms are altered. So in this situation, you think it's acute, but you're not sure. So it's safer again to treat it as chronic. It's kind of the biggest thing. Whenever you're not sure, just treat it as chronic. And target 4 to 6 millimole increases in the first hour to see a change in their symptoms with hypertonic saline. And then avoid overcorrection of 10 to 12 millimoles, but realistically, again, 6 to 8. So let's talk a bit about hypertonic saline. Hypertonic saline was, so first of all, the first kind of death from hyponatremia was actually found in 1936. That's the first documented one. It occurred after a huge amount of free water that was given intraoperatively. And so the same author 2 years later had a similar case, and they ended up giving the patient 130 mLs of 5% saline. And that was enough to treat them, and they documented this in the literature. Over the years, people found that 5% dextrose and 5% saline were easily confused. And so they switched it to actually, the manufacturer switched it to 3% normal saline instead. And then 3% normal saline kind of became, in terms of giving that versus other methods of treatment, became kind of in the spotlight in 2005. Around a lot of literature around exercise-associated hyponatremia and marathon runners, where they suggested trialing this for patients who, after a marathon, were found to be very hyponatremic. There's another way to treat patients as well, and that's using equations like this hideous thing on the left side here that some of you may have had to calculate before. It's an equation that's used to figure out how much does this patient require in terms of a continuous infusion of hypertonic saline in order to correct their sodium. And so these are kind of the two ways, boluses and then continuous infusions based upon these formulae that were decided in terms of how you're going to treat patients with hyponatremia. A few things to know about hypertonic saline just clinically. It doesn't require a central line. It's a common misconception, or a lot of times you'll find people they're resistant and they want to get a central line in before they run it, but it can be run peripherally. Typically a 2 cc per kilogram bolus is going to increase your sodium by 2 to 3 millimoles per liter. And 4 to 6 millimoles per liter, as we said earlier, is something that should alleviate symptoms of cerebral edema related to hyponatremia. So 2 boluses, if you give it to a patient and they're not improving, you should really be thinking there's something else going on. The other thing to know is that if you're in a pinch and you have no 3% saline, or you're taking a little while to get the bag ready, from the crash cart, you can actually use bicarb, which is roughly equivalent osmolarity-wise sodium bicarbonate to about 6% normal saline. So about twice the strength of 3%. And so 1 amp, which is 50 milliliters, is equal to about 100 mLs of 3% normal saline. And so that's a useful thing to know. And we'll talk about how you're going to dose it afterwards to get an idea. But typically 2 cc's per kilogram is what you're going to be looking at. So you can use that to calculate how many amps. And often people just say give 2 and then reassess. So let's talk about infusion methods, because this is kind of what really started to interest me. Because I've seen people giving continuous before. Like, I thought I'd heard about it at some point, and I saw people giving boluses, and I was wondering, okay, what's kind of like the difference? Like, why would we do one or the other? And so what happened is that people used to do continuous quite frequently. And South Korea actually, until recently, was still using continuous infusions. But in 2013 through 2017, the European and North American guidelines I referenced started suggesting rapid intermittent boluses. And they said the advantages, they kind of called them the fact that you could get a rapid partial correction of sodium because you can give a lot at once early on. There's less math required, which in a busy emerge is a valid point because that's a lot of extra kind of cognitive capacity that's going to lead to medical errors and going to take you away from the flow of the department. And then it also limits the risk of overcorrection because you're not continuously running someone on something. You can give them a bolus and then check how they look afterwards. But the issue was that this was all based upon really like medium to low quality evidence. So the things they cited is, for example, this small RCT comparing oral and IV saline solutions and in 47 patients. And it was really specific to exercise-induced or associated hyponatremia. So it was really marathon runners that were involved in this population. The other evidence they had was case reports. So the case report, which one was an NEGM of someone responding to another article talking about their experience using hypertonic saline. And then the bottom one is a case report from 5 patients from back in the 1970s and 1980s. And then the third kind of category of things they used was expert opinions, and that various different papers. This consensus conference was actually a lot of expert opinion rather than evidence, and the same with these papers on the right side. And so this is what was used to inform this decision. And if you spend time studying hierarchy of evidence, then you know that the bottom two of this pyramid of quality and hierarchy of evidence. There's no really randomized controlled trials that are relevant to the patient population. The only one is in athletes. And there's definitely not any systematic reviews or any filtered information at the higher level of the evidence hierarchy. So that led me to my question. In patients with hyponatremia that require correction with hypertonic saline, is a rapid intermittent bolus a safe and effective method of treatment compared to slow continuous infusion? And so my population was patients requiring 3% saline, hyponatremic patients. The intervention was a rapid intermittent bolus, and the control was a 3% saline through SCI. And the outcome for me was incidence of overcorrection as the primary outcome. And so that kind of in line with PICO, I ended up finding some SALSA. And that takes me to this paper here, the SALSA randomized clinical trial, which was published in October 2020 in JAMA Internal Medicine. And it was published by a group of researchers primarily based out of South Korea. So the study design was a prospective, multi-center, open-label RCT, and it was done at multiple South Korean hospitals. It was done from August 2016 to October 2018, and for the most part, they were emerged patients. However, in the last month they were studied, they had to expand it to include some ward patients to meet sample size, and that's about 1/4 of the sample size. The population inclusion criteria is 18 years patients 18 years and older, and who have a glucose-corrected sodium of less than 125. And so one thing to know is for every 5 that your glucose is above 5, I believe, you have to adjust it by some amount. It's on there's a HippoEM thing about it if you watch that, but I can never remember the numbers. I always look it up. But just know you have to correct it for hyperglycemia, and that kind of comes back to that pseudohyponatremia that we talked about earlier. In terms of their definitions, they include people with moderate or severe symptomatic hyponatremia. And this bottom left chart is from the European guidelines. They didn't follow them exactly, but you can see there's quite a bit of overlap. So moderate was nausea, headache, drowsiness, malaise, weakness. And then severe was vomiting, stupor, seizure, and coma. So I'd say overall it's quite similar, maybe not to a T, but I would say it was similar enough to kind of what was accepted, moderate and severe. The exclusion criteria, a long list of things, but basically what they did was they tried to find people who would be at an altered risk for things like cerebral edema or osmotic demyelination syndrome. So liver disease, you can see there. Increased ICP recently is also known to increase the risk of cerebral edema, as you'd kind of expect. And then pseudohyponatremia at the bottom. So all these different things were used to kind of decide, are we going to include these patients in the study? The intervention was a rapid intermittent bolus of normal saline at 2 milliliters per kilogram. And it was given over 20 minutes. And the way they decided is if patients had severe symptoms, they gave them 2 separate boluses initially. That kind of makes sense, right? 2 milliliters per kilogram, as we know, as I mentioned earlier, would increase your sodium by 2 to 3 millimoles per liter. And you want about a 4 to 6 increase. So giving 2 boluses is very reasonable. After that, they would repeat a bolus every 6 hours while they measured sodiums until the target sodium was achieved. In the control side, they gave a slow continuous infusion, and that was about 1 milliliter per kilogram per hour, or moderately severe patients to get 0.5 per kilogram per hour. And they had this complicated kind of correction step at each checkpoint at 1 hour, 6 hours, 12 hours, and so on to determine how they were going to adjust it. And I'll come back to that in a second. A few things to know about their intervention and controls. The way they kind of decided these groups is they stratified all their patients by symptom severity, so severe and moderately severe. And then they randomized them to rapid intermittent bolus or SCI. And that randomization and allocation was blinded to the researchers, but not to the study coordinators. And then the treatment itself was blinded to the analysts, but not to the patients or to the MRP. This is their kind of overall algorithm. So you can see this is the rapid intermittent bolus ones. Just to quickly go through it at the top. they get either 1 or 2 boluses of hypertonic saline, and then they get their serum sodium checked at 1 and 6 hours. Based upon how much their sodium has changed, either you get observations, another bolus, or some relowering treatment, which is usually through vasopressin. And then that's repeated up until 48 hours. Contrasted to, this is the continuous infusion method, where same kind of idea, they get 1 or 0.5 milliliters per kilogram per hour. And then when the sodium is checked, either they get a change to their rate, adding 0.25, or they get relowering treatment, or the infusion is stopped. And so as you can see, it's quite a bit more mathematically complicated. The primary outcomes were, well, the primary outcome itself was incidence of overcorrection at any given point after 48 hours. And they defined this using kind of that minimum number earlier, but still what I'd say is accepted. So greater than 12 millimoles in 24 hours or 18 millimoles in 48 hours. And then they have a whole slew of secondary outcomes, and that includes like the safety and the efficacy of the treatment, whether they were still symptomatic, things like the incidence of osmotic demyelination syndrome, relowering treatment, hospital length of stay, all that good stuff. In terms of their methods, they analyze these papers through a couple of different methods. So demographic data was analyzed through either giving a mean and a standard deviation, or a frequency and a percentage. The binary variables, so things like incidence of overcorrection, the incidence of additional treatment, ODS, all that, was mapped using chi-squared and Fisher exact tests with 95% confidence intervals and absolute risk differences. And then the continuous variables were things like differences in GCS, the time to achieve a 5 millimole change, were analyzed through linear regression, as well as a t-test / Mann-Whitney U test. Overall, the results, we'll go through them quickly because I'm a bit short on time, is that they had about 313 people who were eligible, and then 178 that ended up becoming part of the study. They had 2 kind of analyses. They had their intention to treat, which is the 87 and 91 people that you can see that were initially randomized to each group. And they had their per protocol, because a couple of people had to be violated either due to non-adherence, due to error or unfamiliarity, or other medical causes, or violation of protocol. And so there's some exclusion of patients. And so the per protocol analysis really just includes the 72 and 73 at the bottom, whereas the intention to treat analysis includes the 87 and the 91 at the top. So the results overall, these are the demographics. And so just a few things to point out. You can see the age is quite similar between both groups. The average weight of patients also quite similar. In terms of reasons for causes of hyponatremia, it was primarily people who had adrenal insufficiency, SIADH, or thiazide use. And then comorbidities were also pretty similar, I would say, between both groups. And the big ones you think about, like liver cirrhosis, and chronic alcoholism, that are going to affect your osmotic demyelination risk, were both similar between the groups, which is important. In terms of other things, they had very similar sodium values, 118.2 on average. And then symptoms-wise as well, they both had about the same number of moderate and severe symptoms, which we expect because they one-to-one stratified and then randomized them based upon that. In terms of their primary outcome, the results showed this. So in the RIB, the rapid intermittent bolus group, the overcorrection rates are about 17.2%, while in the SCI group, there's a 24.2% overcorrection rate. And you can see both the per protocol and the intention to treat analysis showing the rates of overcorrection over time. Now, at first you think this is like, oh, this is a pretty good result. But if you look at the actual absolute risk difference, it's negative 6.9, saying that RIB has a lower risk than SCI. But the confidence interval does surpass 0. So it goes from negative 18.8 to positive 4.9%. And so really you can't call that statistically significant, and the p-value is 0.26 because of the fact that within the confidence interval, there could be either a decrease or an increased risk. We can't say for sure. And so while there seems to be some signal that perhaps one is better than the other, this is what I would call an insignificant result. And the way they ended up calling this in the end was that there was no risk difference between the 2 groups. The secondary outcomes, there's a whole bunch of them. I think the big ones to know, and looking at the p-values on the right side here, is that there was, in the RBI group, there was an incidence of additional treatment required. That makes sense because you're giving individual boluses, so you're going to need more treatments if you're doing the RBI group. Whereas in the continuous infusion, you can kind of do your calculations and you leave it. But on the other hand of that, the SCI group also required more relowering treatments here. You can see that under the safety section. And that was actually a significant value. People required more relowering if they were getting SCI. And so they actually calculated the number needed to treat to prevent the need for relowering treatment of sodium. So the sodium has gone too high, now you have to bring it back down, of 6.3 if you use rapid intermittent bolus. The other thing they really commented on was at 1 hour, patients with RIB had a higher rate of correction versus that SCI. And so they said, in a severe patient, that's a better outcome because at 1 hour, you really want to bring their sodium back up. And so you can see the differences here, the blue line being rapid intermittent bolus, and then the yellowish orange line being SCI. And at 1 hour, you can see in each one, and the intention to treat as well as the per protocol, you can see that the RIB has shown more improvement. I would say not really, because if you look at the amount in the left side column here, the 220 is RIB and 38.6 is SCI. This is how much hypertonic saline they get within 1 hour. And that's just kind of how bolusing versus a continuous infusion works. So of course, if you get more sodium within the first hour, you're gonna have a higher sodium that comes back. So I would say that result is kind of logically expected. So let's do the critical appraisal quickly. A few things. So I got a lot of these questions using the Skeptic's Guide to Emergency Medicine. I find they have a really good template for how to analyze and critically appraise RCTs. So was it relevant to the emerge? Yes. The patients were randomized, and I thought they did a good job with stratification and allocating 1-to-1. And the randomization process was concealed from the analysts. So only the study coordinators were aware of this. The patients were analyzed in the way that they were randomized. And I would say the two groups were similar in terms of demographic and prognostic factors. The weaknesses come on this second slide. So the patients in RRP were not blinded. And that does lead to some bias because now, if you already have a preconception that SCI is going to need higher risks of relowering, then you're more likely to have a lower threshold to relower somebody. Or at least maybe you're going to be thinking about that a bit more than in a rapid intermittent bolus patient. It's hard to say if the patients were treated equally except for intervention. We don't really know that information, and so that was unclear. Follow-up was good for the patients, and I thought all patient important outcomes were considered for this. And then I would say the treatment effect was not large enough to be precise enough to be clinically significant. And I say that because our primary outcome, the confidence interval is so wide that we can't really comment on anything there. If they had a bigger population, maybe we would have seen a benefit. The strength of this paper, though, is that compared to the other evidence that we saw before this to inform our decision for rapid intermittent bolus, I would say this is much stronger. It's our first kind of good quality RCT relevant to the emergency department on this topic. And it answers a clinically relevant question. There's a good follow-through rate, and I thought both groups were very similar in terms of their baseline characteristics, allowing us to get some good information from this. The limitations was the wide confidence interval. There's also no cases of osmotic demyelination syndrome, and it is very rare. But when that's kind of the major outcome of interest, perhaps a large population size where we can get a few of those cases would be very helpful for us. And then other things are kind of the changes in enrollment to include ward patients towards the end, the lack of blinding, and then the fact that some things like the osmolarity, which is used as an exclusion criteria, may not be readily available and may not apply to the decisions we make in the emerge. So the clinical bottom line is I would say it's first of its kind study, it's relatively well done, and I'd call it a negative study. But I think that's actually good for us because really the question is, do we want to do the more cumbersome SCI treatment or do we want to use rapid intermittent bolus? And what this is showing is that it doesn't really seem like there's much of a difference. Maybe RIV is better, but not really sure. And so the benefits for rapid intermittent bolus still stand. It's simpler than continuous infusions. It's more rapid correction, which is great for severe patients. And there's a lower rate of relowering therapy, which the question is this a bias or not? But regardless of the two, I would say the first 2 points still make enough of a case that it's worth using that as your dominant strategy. And so this is my takeaway from this. I think I would opt to use a rapid intermittent bolus strategy for hyponatremic patients. And I would use a 2 milliliter per kilogram bolus over 20 minutes. And so if patients have severe symptoms, I would give them 2 boluses. If they have moderately severe symptoms, I would give them 1. And then I would check their sodium at 1 hour and then every 6 hours. I would target a 4 to 6 millimole increase in the first hour. And then in a full 24-hour period, I wouldn't go over 12 millimoles, but realistically, you don't really get a whole lot of benefit over increasing that 4 to 6 range. So I don't think I would really be overzealous about getting it above even 8 millimoles per day. And then within the first 48 hours, when they're up on the ward, you want to make sure there's less than 18 millimoles of correction. And so that's my study. That's my cat topic. I'm happy to take any questions, and I apologize. I think I went a bit over.
Thank you so much for the presentation. No, it's fine. We had a bit of time to go over in the context. Our next presenter was nice enough not to be okay with it. Do you guys have any questions?
I guess I have more of a comment, really. It's a good topic. I think it's interesting. And I think another thing to point out is they didn't find any specific effects in a well-controlled study, right? Which is not the environment that we necessarily work in, where once you start your slow infusion, you're probably monitoring it better. You're probably checking those sodiums more frequently. And we don't live in that environment, unfortunately. And especially when you put into the mix things like sign over and busy emerges, it seems to me like it's even safer to use a rapid bolus, because you're less likely to sort of accidentally leave on that slow infusion or miss the sodium check. And then you're even more likely to run into those errors of overcorrection potentially. We also don't know exactly when it started, so it seems like it's a lot less cognitively cumbersome to use a rapid infusion strategy here as well.
Yeah, agreed, exactly. I think it's just a much more logistically sound and error-proof method. And now we have some evidence that says that doing one is not superior to the other. So if you have that, then we know all those extra things, it's worth doing the RIB. Thank you.
All right. So I will forego the rest of the questions just to move on. But thank you so much, Dennis. That was awesome. And post-call 5 nights in a row, that's solid. So you deserve some salsa and chips now. Or maybe go to sleep first. And then,
I might do that first.
Afterwards, get some tacos too or something. So,
definitely. Thanks, guys.
All right. Yeah. Okay. So I'm very excited to welcome Dr. Mark Waba. So this is from my, you could argue home base or my background in Saskatchewan. So Dr. Mark Waba is a transport physician for the Shock Trauma Air Rescue Service, or STARS, Saskatoon, and also a staff emergency physician in the Saskatoon Health Region, which I guess now is, I think, the Saskatchewan Health Authority. But anyway, so without further ado, I'm very excited to welcome Dr. Waba, one of our first guest speakers from outside of the province today. So Dr. Waba, you can go ahead and start sharing your screen. Tanish, you might need to stop sharing your screen.
All right, good morning, everyone. Thanks for that introduction. Jake, and the classic words that everyone says now on Zoom, you can hear me okay? I like thumbs up. If people give me thumbs up, that helps me out. Okay, good.
I can hear you for sure.
Okay, cool. So thanks very much for having me today, Jake, and the team in McGill. I'm honored to join your rounds. But I got a question. What's the first cat of the year? What does that mean that Marta said in the chat there? Help me out with that.
I forget what the acronym stands for. Go ahead.
Critically appraised topic is that's right.
Right. I drew a blank. Yeah.
Okay. Critical appraisal topic. Okay. Great. Well, my talk today, it won't be so critically appraisal or super academic. Jake had asked me to talk about my the experience I had with this carbon monoxide exposure case in Saskatchewan in January earlier this year, and I said, well, sure, I'm happy to talk about it. As long as you guys talk about the pathophysiology component in a different environment, I'm happy to tell you what I experienced and what I learned from that. And so what I really want to talk about today is kind of a few things that I'm hoping you can take away from this case that really fit in, I think, with the CanMEDS criteria, and that learned that when you make a diagnosis, it's more than just the studying and the book stuff that goes into it. All these other factors that came into this diagnosis that I hadn't really appreciated until afterwards. So hopefully you can take something out of it with that. So I do want to share my screen here. So just give me a second to sort that out. All right, people seeing that?
Yeah, I can see it.
Okay, perfect. Thanks for that, Jake. So the first thing, these are the 5 things I want you to take away from this today. The importance of a positive handover culture, the importance of respect and building community relationships, and to do what interests you in medicine as you get into it. Like, if you think that's cool, but maybe there's no job in it, don't worry about it. Just do it because you think it's cool. And then resilience. And then the other thing is control. and influence, and what you can control, what you can influence, and then what you can do neither. Okay, so those are the things that I really want to share with you, right? And I'm gonna have to toggle back and forth a little bit, but the story was that it was in January of this year. It was really cold, a super busy night, and COVID restrictions and workflow problems. And my colleague came up to me and said, yeah, oh, sorry, I got one patient I got to hand over. I signed up for her. She's over in peds with her kid, but I keep getting interrupted, and I can't get over there. She said it's not easy. There's a significant language barrier. Now she's out in the waiting room for 6 hours. So I think it was Seth that talked about earlier when you mentioned some comments. You talked about sign over and handover in a busy department. And so the first thing that I think I want you to take away as you move on with your careers is the importance of finding a culture where you have a positive handover culture and an accepting culture. And I think this fits in with the CanMed's criteria of communicator and professional. So when you handover is one of the biggest causes for medical error and harm. And that's where mistakes are going to happen. So we were busy, language barrier, it was a handover. And as the doc coming on, you're just kind of getting into things, be really vigilant on the handover. When you take those patients, go take a look at them and review them, because that's where your mistakes are going to happen. So
Dr. Waba?
Yeah.
So sorry to interrupt. Is it normal we don't see your slides anymore?
Yes, thank you. Yeah, I'm going to try to toggle back and forth between slides.
Oh, okay, no problem. Sorry.
No, it's okay. In fact, but actually, you know what? While we're pausing, can you see me if I talk? Can you see my slides at the same time?
Yes, yeah. Like if your slides are up, we can see you as well. Yeah.
Okay, you know, we can try that. That's work. But yeah, that's how you kind of. So how's that? Is that better for you?
That's perfect. Yeah, I can see you and the slides. Yeah.
There's not a lot on the slides. I usually just like mostly talking, not a lot of slides. But this lady, so she just arrived in Canada 3 weeks prior. There was a language barrier. She spoke no English. She's waiting for 6 hours. I examined her. I can't find anything on exam. I think it's completely benign. I thought, oh, we'll do a CT scan of her head. Maybe this is a venous sinus thrombosis or something odd, but it is normal. And I have nothing for a diagnosis for this lady. And I told them, I think your headache's from a recent move to Canada and all the stress that you're going through and leaving the refugee camp. And I think that you're stressed. And the translator then says, well, yeah, they couldn't find anything in the other side with the pediatric department with her child. And I thought, that's weird. And I had a resident or a student working with me at the time. And so because you have a student, you're always talking out loud, and which also I think fits in the CanMed's role, I believe, educator. But you're always talking, making your thoughts out loud, and what are you doing? And I said, that's strange. Maybe this is carbon monoxide. Like, why do they both have a headache? So I phoned the fire department, and that's going to step into the next one. So I phoned the fire department and I said to them, can you just go check on this apartment building? I wonder if this is carbon monoxide. And the fire department said, yeah, we'll go check it out. And sure enough, 10 minutes later, the lady from the fire department phones me back and says, you're right. It's carbon monoxide. It's 300 parts per million. And I said to her, oh, is that high? And she's like, yeah, it's incredibly high. They're evacuating the building. And I was like, oh my God, I couldn't believe it. So that goes into the second slide. And that's respecting and building your community relationships. And the importance of this. So over your career, you're going to meet and you're going to encounter many community groups and resources, right? Police, fire, EMS, social workers, addiction workers, groups in the community that you might interact with, homeless shelters, right? We always, in Saskatoon, we have a number of, I'm sure you in Montreal as well are no different, but you're interacting with these homeless shelters. Build those relationships and do a good job of that. Don't be arrogant and think you know everything. And are you familiar with the Dunning-Kruger effect? Have you talked about this yet in your, maybe just, I can see Jake, I can see you, and so the other chief.
Not specifically, no.
Not familiar with Dunning-Kruger? Okay, I'm just going to go back to a lot. So Dunning-Kruger talks about that when you're early on in your career, you think you know everything. And we all go through this. It doesn't matter what, if it's medicine or whatever you're in. And it's worth Googling and kind of reading about. But we all hit the peak of Mount Stupid, where, and I was classic for this when I was done my residency, because you have so much knowledge and you think you got it all. And you're really kind of cocky and arrogant. And then you go into this valley of despair after you make some mistakes. So where I'm going with this, just give me a second to tell back here to this one, but I remember where I'm going with the Valley of Despair and the Dunning-Kruger effect. I got some feedback once that I was in a 360 review that I was dismissive to the EMS staff. And that really affected me. I thought, man, that's no good. I don't want to be known as that. So I worked hard at my relationships with EMS and community resources. And I think it paid off. So a few years ago, the fire department contacted me because I was working in some leadership position. I worked with them a bit, and they said, hey, can you help us out with a medication called Penthrox? Now, I don't think Penthrox was new to Canada at the time. So I just want to show you a picture of Penthrox here. Okay, anyone seen this, Penthrox? I can only see two people there, but it's a medication called methoxyflurane, and you inhale it. And the thing was, when the fire department asked me if I could help them out with this, I was like, yeah, I could try. I could help you out with that, because I had used seen Penthrox before when I went to New Zealand. And my wife and I, we took our kids and we worked in New Zealand for a year. And that kind of takes me to the third point. Actually, I'm going to go back on my slide here, but it's to do what interests you. So I was working a good job, working with STARS, working here in Emerge. Things were great, but my wife and I like to travel and see other cultures. And we thought, let's go overseas. And I took a job in New Zealand for a year. And that's where I learned about this medication, Penthrox. And the thing about this is to do what you're interested in it. There's a book called, here I'm going to stop sharing my screen because I want to show you this. This book called Johnny Bunko. Have anyone seen this? It's a manga book by Daniel Pink. And Daniel Pink used to write for Al Gore, and he wrote the speeches for Al Gore. So he's got a book called Drive, and he's got a Pink cast. He's really good to listen to. But he talks about the difference between instrumental and fundamental decisions in your life when you're faced with them. And an instrumental decision is something you're going to do. You do it, you make that decision because you think it's going to lead to something in the future. It's going to get you somewhere. And a fundamental decision is you do something because you think that's cool, and I'm passionate about that, and I want to do that. And what Daniel Pink says is always take the fundamental decision. Like, you think that's interesting, do it. Even if there's no job at the end, it's because you're passionate about it. Because you can't predict the future. You don't know what's going to happen. You don't know if you're going to get sick, or your partner's going to get sick, or maybe you win the lottery, or the market changes, or COVID comes. You don't know. So the instrumental decision doesn't always pay off, but the fundamental one does. So we had made this fundamental decision that we wanted to go to New Zealand, and that worked out for us. So it's gonna tie back into this carbon monoxide diagnosis here in a second. I've got to share again here. So do what interests you. Okay, take that fundamental decision. So where I'm going here is, if I hadn't gone to New Zealand and made this fundamental decision, I wouldn't have learned about Penthrox. And if I don't learn about Penthrox, and there's this whole other analgesia that I've never even seen before in Canada, when the fire department says to me, hey, do you know about Penthrox? I can't say that, right? So if I don't have that relationship with the fire department, maybe it's not as easy for me to pick up the phone and say, hey, can you do me a favor? Can you go just check on this patient, on this building, and see, is that okay? So do what you're passionate about. So what ends up happening is the fire department goes and checks on this building, and 29 people get evacuated from the building. We have this code orange. Fortunately, everyone does well. We get to them before the carbon monoxide does, quite frankly. But I think about that, and I think, this could have been a career-ending miss for me, right? Like, I missed that diagnosis, and that lady goes home, and her kid, maybe they die, her and her child. Maybe some of the 29 people in that building die. Maybe they all die. Right? Like, that's devastating. And what I want you to think about there is resilience. And there's a lot of talk about resilience right now in medicine. And I think this fits in with professional and leader. And I'll review those CanMed's competencies at the end here. But don't downplay this. Don't ignore this. Take care of yourselves and your mental health. And I think where you can build your resilience is talking about your mistakes with your colleagues and your misses. And I don't know why we don't do this more in medicine. I've always wondered why we don't have, this is what I missed rounds. Because if you talk in fact, even yesterday I was with a resident and another staff person, and we were talking about the things that we miss. And my friend Lance, the other doc, said to the resident, yeah, don't make all the mistakes yourself. Share your mistakes with your colleagues so that we can learn from them. And I think that you know, that's where you're going to build your resilience, is this, you recognize you're not perfect, and it's the small things, so that you can accept them when things don't go well, because things don't always go well. And we talk about the diagnostic error rate being 15% in medicine. And like, I'm no super diagnostician. This worked out for me one day, but I missed, my wife had optic neuritis for 3 weeks and I couldn't figure it out. So I'm not perfect. Nobody's perfect. And to acknowledge that and realize that we're going to make mistakes, and that as you work to learn from your mistakes and your colleagues' mistakes, that will help build your resilience. And part of resilience then gets into our fifth point. And really, that's knowing what you can control, what you can influence, and what's beyond your control and influence, and is a concern. So like, I can control my mood, I can control my attitude. I can influence the mood and attitude in my house, with my family, my kids, my behavior, how I come home when I'm, my attitude when I come home from work. Am I happy? Am I sad? So I can influence that. But I can't influence or control the weather outside. That's a concern to me. What are they going to wear to school? But I can't fix that. I can't control that. And where this fits in is really with the health advocate. So, and here's a slide on circles. Maybe you've seen this. I think it's from Stephen Covey and the 7 Habits of Highly Effective People, but circle of control, circle of influence, and circle of concern. So that's a good one to think about, and really think about what can you control. So what ended up happening was one of the paramedics that evening, when the fire department showed up and the media showed up, they mentioned that it was me that had called, I'll go off slide for a second here, had informed the fire department. And the next day it was like all these media requests and wanting to talk, and I was super overwhelmed. So I reached out to my SHA, SALSA Health Authority communications person who I'd worked with. I said, look, I'm getting overwhelmed here. And he said, well, we can help you with that. And then I didn't really want to talk about it. I didn't want to do much. I just like to go to work, see the patients, come home, take it easy. And I got an email. I was getting emails and messages from people, and I got one from somebody in rural Saskatchewan, and she said to me, don't downplay this. Like, you use this as an opportunity to draw attention to the problem. And I thought, yeah, she's right. And I like quality improvement, and I like patient safety. And I thought, how do we prevent this from happening again? What can we change? So I said to communications people, yeah, I'll do it. And did this media interview. And in the media interview, I said, it would be great if we could make a change after this. That maybe we never have to have another carbon monoxide poisoning case again if we can get carbon monoxide detectors in every household in the province. And I kind of called out the government. So it would be great if the government can change the laws on this right now and work to that. And we got our emergency medicine section for the Saskatchewan Medical Association. We, at the representative council meeting that happens twice a year, we got them to pass a motion to advocate for the government to try to put carbon monoxide detectors in all homes. And I'm pleased to say that just over 3 weeks ago, and Jake, I don't know if you know this since we last spoken, but starting July 1st, 2022, all buildings in Saskatchewan now must have carbon monoxide detectors. So it changed we were actually able to change the legislation, and they're working. That'll be it next year. So I just want to show you the quick screen clipping of that one. So this was the headline that came out September 15th. So I can't control this, right? I can't control what the government does. But as a physician, you can influence what the government does, and you can be an advocate for better health for people. So use that. You're professionals, and you can advocate, and you can make healthcare better for people. So with that, I think one more final slide here just to summarize, really. But these are the 5 things that I took away from it as I reflect, and I hope you can take away from it that do fit in with CanMeds. So look for a positive handover culture. when you're getting your jobs and you do your locums around? Like, do people just walk out at the end of shift and say, good luck with that, Mark, that person needs an LP? Or is it collaborative? And do you talk to the patient at the bedside? Do the three of you, the patient and the two docs, okay, this is the plan, does everybody agree? Yeah, we're all on board. What does your culture look like? That really fits in being a professional and communicator. Respect and build those community relationships. As I talked about, if I hadn't worked with the fire, maybe I wouldn't have been thought to have called them and say, hey, can you help me out? And do what interests you. If we hadn't been interested in going overseas, I'd never have known about Penthrox, which would have never led me to work with the fire department as intimately as I did, and which led to ultimately this relationship. Resilience. So I think doing what interests you fits in with being a scholar. As you're constantly learning, like, I'm interested in that, I want to learn about that, I want to do that. And respectability, community relationships, of course, as a collaborator. And then resilience. Work on the things to, we talk just too much talk about resilience, but the point I want to make is that talk about your mistakes with your friends. What did you miss? Help them and they will help you. That's being a professional and a leader. You can set an example by being open about when you miss something. I've missed tons of things over my career. And the more you talk about it, you realize everyone's missed something. And then finally, what can you control? What can you influence? And what is beyond your either, and it's really a concern. And that's really a health advocate. You can influence the health of the population with your job and your profession. And with that, I hope that was a little bit different than, I know I'm between you and lunch, so I hope that was interesting for you. I'm happy to talk more if you had questions or if that was useful, but I'm happy to talk as much as you want or as little as you want.
Oh, you go, Jake.
Sure. Just to start, I mean, that's a lot. That's a lot of great stuff. And did you find that the community in Saskatoon, in the Saskatoon Emergency Department, like, did this trigger any? You talked about being a health advocate and making change. I know that this one was very specific to that case, but has anyone else in the emergency department there taken up their own initiatives based on your experience?
I wouldn't say based on my experience in January. Other people certainly advocates in their own way. I know we have one member, well, you know, Brittany Ellis. She's a huge she's a huge advocate for geriatrics and geriatric care in the emergency department. And so she works really hard at that. And we have some people that do some addictions work and try to help in the inner city there. So I think everyone finds their own area and tries to advocate for that as much as they can.
So thank you so much for your talk. There's two things that you said that I think deserve like being very highlighted. I think I agree with the importance of the positive handover culture. We see, I think as residents, we're privileged to see different residents, fellows, and staff receiving sign-overs and making them. And like, to me, a lot of people have different attitude toward it. And it's good to be, I think, kind to each other, and especially maybe post-night where it's been a crazy thing and like nobody died, like they've done their job, and to take over. I think that needs to be, we all get tired sometimes, and like it needs to be emphasized. And the other thing is that you talk about the importance of sharing our mistakes. I think it increases whenever a staff or somebody comes to me and says, I've done that mistake and that happened, it just increases your respect for that person. It's just positive.
Yeah, I agree with you. I think we're all human and we all make mistakes, and no one, I think early on, I remember early on in my career, as a medical student, you think you're going to do everything right and you're going to always get the diagnosis. And the more you get into it, the more you realize you don't know, and you make mistakes. And to talk about that with your peers, I think you do get more respect, but it shows that you're vulnerable. And if you're vulnerable, I think people can respect that more. And your comment about taking over patients in the morning, I agree. I think that I've often thought maybe we look at, should we think about how we approach medicine different for the time of day and at night? I think maybe we should just be trying to keep those people alive, because you're not on your game 100%. But the 8 a.m. doc or the 6 or 7 a.m. doc that comes on, it's their job to be like, I'll take whatever you need and help you out and take it off your plate so you can get home and rest, and I will figure that out. And so I think we try to foster that culture, and I think you're right with that.
I had a comment. I just wanted to say thank you so much. That was a fantastic talk. My name's Gemma. I'm part of the CCFP EM+1 program. And just along the lines of like giving people some slack, I think that a lot of the time, the more that we are harsh with ourselves and the more that we berate ourselves, often subconsciously, about our own mistakes, the more likely we are to judge quickly the mistakes of others. And I find that it happens so automatically where someone may have missed something that to an outsider is very obvious, whether that's your staff or your peer. It's so easy to be like, oh my gosh, they missed this. They don't know how to apply this rule. And it's so easy to do that without taking into account the like multiple complex factors that probably went into the reason that mistake happened. So I think if we can, I don't know which is easier to start with, but maybe it's easier to start with your peers, and then hopefully that will turn around and impact the way you speak to yourself as well. But I think it would really make such a big difference to everybody. So anyway, I just wanted to say great talk, and I really enjoyed that.
Oh, thanks. Thank you. Yeah, I think you're right. You said something there about berating ourselves, and you can get into this cycle of negative self-talk. And they talk about that gremlin on your shoulder. I think there's a book, my friend had told me about that one, and that because we're in a profession that it's demanding, and everyone's pushes towards that perfectionist end, right? You want to do well, you want to do it right all the time, and when you don't, you can beat yourself up. So it's very, like Gemma, like you said, you have to be kind to yourself and catch yourself when you're berating yourself. And I do it still. Like I still will catch myself getting down. Like, man, you know what? None of this negative self-talk. There's a lot of positive things I bring to the job and to the family. I don't go down that negative self-talk.
All right. Any other questions? Okay, well, thank you so much, Dr. Waba. Like, I appreciate you traveling all the way over here from Saskatchewan, yeah, figuratively. No no, that was amazing. Thanks so much. And so many good learning points along the way beyond just the pathology of the case itself. So thank you so much.
Great. Thanks,
Jake.
Right. Thanks, everyone.
Have a great morning. Yeah. Thank you. Talk to you later. Bye.
So guys, don't forget about RPC.